You have two type of mutations in it. I mean, mutations can be many type in case of beta thalassemia, right? It could be a splice site mutation, could be a promoter sequence defect, it could be a Kozak sequence mutation, right? And all of these mutations can lead to the beta thalassemia, right? So it is an example of allelic heterogeneity, right? Where you have multiple mutations on a single gene, and all these mutations can lead to one phenotypic effect, right? And then we discussed about the beta thalassemia major and the minor. We have discussed how in case of minor, you will have some level of HbA1 as well as HbA2 present, while in case of beta thalassemia major, you just have the HbA2, okay, or the HbF. No HbA1 is present in that case. And the HbF is kind of is very much protective for the beta thalassemia major, okay. And yeah, the symptoms of it will arise only after 6 months, okay. So, and we've discussed about the hepatosplenomegaly. Why the hepatosplenomegaly is happening in case of beta thalassemia? It is because of migration of these cells of the progenitor cells from the bone marrow to the liver and spleen for the erythropoiesis, right? So it would be due to the extramedullary hematopoiesis. Okay. Now the other causes of microcytic hypochromic anemias. Is my voice okay now, or is it still breaking?
It's okay now.
Okay.
Yep.
Okay. So now the other causes of microcytic hypochromic anemias, and the first one is the lead poisoning. Okay, lead is basically a toxin that can inhibit the ferrochelatase, okay, and the ALA dehydratase. If you guys remember the formation of the these porphyrins, let me show you. Yeah, for the formation of heme, you first have the glycine and the succinyl coenzyme made. Okay, like we have discussed already. This glycine and succinyl this coenzyme A combine in the presence of this vitamin B6, okay, and the ALA synthetase enzyme to form the ALA, which is aminolevulinic acid, right? This ALA will convert it into the porphobilinogen with the help of enzyme ALA dehydratase. Okay, the porphobilinogen will be converted into the hydroxymethylbilene, okay, and then the uroporphyrinogen, okay, and then this uroporphyrin will be converted into the cropoporphyrin with the help of enzyme uroporphyrin decarboxylase, okay, and then the corpoporphyrin 3 will be converted into the protoporphyrin, right? This protoporphyrin will be combined with the iron in the presence of enzyme ferrochelatase to form the heme. Okay, this is a whole pathway, and two areas are involved, or this cycle will be run into two sides. Okay, one is the cytoplasm and second is the mitochondria. The first and the last stage of this cycle, okay, it will happen in the mitochondria, while rest of the stages will happen in the cytoplasm, right? So whenever the patient intakes the lead, okay, this lead will inhibit this enzyme, which is the aminolevulinic acid and the ferrochelatase. As a result, the levels of the this phosphobilinogen will be decreased, okay, and the level of heme will be decreased, okay. So that will happen if you give the patient lead. It will decrease the heme synthesis and increase the RBC protoporphyrin. Remember, this porphyrin will be combined with the iron to form the heme. If this reaction is inhibited, then the level of the protoporphyrins will be increased. Okay, this lead can also inhibit the this rRNA degradation. Okay, and as a result, the RBCs retain the aggregates of the rRNA. So what you will have is the basophilic stippling. Okay, so two things are going to happen. One is the inhibition of these enzymes, and second is the inhibition of rRNA degradation. So rRNA will be present in the mature RBCs, and they will appear as the bluish kind of aggregates in them, which are the basophilic stippling. Okay. Now, the symptoms of the lead poisoning, you will have the lead lines on the gingiva. Okay, and then you have the encephalopathy. Okay, you will have the basophilic stippling of the RBCs, or you will have the abdominal pain. Of course, you will have the sideroblastic anemia. Okay, because this heme synthesis is now inhibited, all the iron will be start accumulating in the progenitor cells. Okay, and that will be seen as the this sideroblastic anemia and the iron deposits within the cells, right? And yeah, you will see these kind of ring sideroblast. Okay, you will have to do the Persian blue staining in order to visualize the ring sideroblast. Okay, this you can also see in the lead poisoning, right? You will have the neuropathies in which you have the paralysis, right? You will have the foot drop, you will have the wrist drop, right? And yeah, so these are symptoms. Symptoms include the abdominal pain, okay, constipation, headache, or you can say a non-specific as symptoms, right? It includes a nephropathy, includes a neuropathy, okay, behavioral changes could be there, psychiatric changes could be there, right? As well as the mechanical changes could be there. The patient can get a paralysis also, right? So always for the lead poisoning, look for the patient history, okay, where they live, where they work. Okay, generally it could be a industrial worker, okay, who is a painter or some kind of a plumber, okay. Sometimes it could be a patient who is working on a battery factory, okay. For the battery manufacturation, you use the lead, okay, or or it could be a patient from the from the ammunition factory, okay, because in the ammunition you uses the lead, right? Or it could be a policeman, right? Or sometimes it could be a patient from an old house, okay, because in old house, okay, we used to use the lead in the old house, right? But as soon as the government discovered that the lead can cause this kind of things, the lead will be banned from the using. Okay, so in the old house, if the patient has a history of any primitive area or the old house, that means they can have the lead exposure in the house, right? So look for these kind of hints, okay, and look for this abdominal, this GI symptoms, neurological symptoms, right, and the anemia thing. Then you will be able to know the patient is having a lead poisoning. For the treatment, you will use the dimercaprol and the EDTA. These are the first line therapies. Saximers can also be used for the kids. Okay, exposure will be the risk of the exposure will be increased in the old houses with the chipped paint, because earlier the lead will be used in the paints, right? But as soon as it was discovered that the lead can cause these kind of things, the lead was banned from the paints. Okay, so only the old house can still have this lead thing in the paints. Okay, and that's why these patients can have this symptoms of the lead poisoning. Is that okay?
Yeah, I have one question.
Yes.
Why did you say that police can be at a high risk of lead poisoning?
Ammunition.
Okay, yeah.
You use the lead in the ammunitions, right? So they can be exposed to it.
Okay, got it. Thank you.
So any person you think would they can be exposed to the lead, right? So please just remember, where they can get this kind of thing, right? The anemia from the lead poisoning. Oh, okay. Now comes the sideroblastic anemia. Okay, and the sideroblastic anemia can be acquired or it could be a hereditary cause also. Okay, generally it could be a X-linked defect in the ALA synthetase gene. See, in the lead poisoning, you are having a deficiency or an inhibition of the ALA dehydratase. In case of sideroblastic anemia, you are having a inhibition or a deficiency or the mutation in the ALA synthetase. Okay, it could be also acquired. Okay, it could be due to the alcoholism, very important cause. Okay, it could be due to the vitamin B6 deficiency. Because of the alcoholism, you can get the vitamin B6 deficiency also, right? So remember, alcohol is a very common cause. Okay, vitamin B6 deficiency is a common cause. At some point, lead can also inhibit this ALA synthetase gene. See, majorly the lead inhibits the ALA dehydratase and the ferrochelatase, right? But it can also inhibit the ALA synthetase very minorly, and if you take the lead in very high amount, then it can also inhibit this kind of gene, right? The copper deficiency can cause it. Okay, the drugs like the isoniazid and the linezolid, okay, they can also cause it. So it could be a patient on the TB therapy, right? But they can have this kind of anemia, the sideroblastic anemia. So remember that. And when you have the vitamin B6 deficiency, and because you guys know that the glycine and this uh, sectional coenzyme will be converted into the ALA with the help of vitamin B6 and this ALA synthetase, right? So in case of vitamin B6 deficiency, you can also have the sideroblastic anemia. Along with the sideroblastic anemia, you can also have the neurological problems with the vitamin B6 deficiency, because you guys know that this vitamin B6 is involved in the neurotransmitter synthesis, right? So a case of paralysis, or sometimes the OCP use could be there, or other histories where patient can have a vitamin B6 with deficiency. You can suspect the sideroblastic anemia also, right? And just like lead poisoning, you will have this kind of ring sideroblast in it, okay, because the iron will be start accumulating in the RBC progenitor cells, okay, and you will have this ring sideroblast in the bone marrow, okay. On the PBS, you will have the hypochromic anemias, the microcytic and the hypochromic anemias, right? You will have the pallor, fatigue, and all the signs of anemia would be there, okay. And yeah, on the lab findings, you will have the high iron stores, because the iron will be start accumulating inside the cells, okay. And you will have the high ferritin also, right? You will have, because of high ferritin, you will have the low TIBC or the normal TIBC, okay, very important. And you will also have this basophilic stippling of the RBCs, okay. And yeah, the treatment will be includes to giving the patient vitamin B6, which is a cofactor for the ALA synthetase. Okay, so on the PBS, you will have the hypochromic microcytic anemia as well as the basophilic stippling. On the bone marrow examination, you will be having the ring sideroblast for the sideroblastic anemia. Okay, and it is because of the inhibition of ALA synthetase. Is that okay?
Yes.
Okay, so we're done with the microcytic hypochromic anemias, all the causes of it. Okay, let's discuss the interpretation of the iron studies. See, whenever you have a low serum iron levels, okay, and low ferritin means high TIBC, because the affinity of the transferrin for this iron will be increased in case of low ferritin. Okay, so they always go opposite to each other. Okay, whenever you have a low ferritin, you will have a high TIBC. Whenever you have a high ferritin, you will have a low TIBC. So in case of a iron deficiency anemia, you will be having a deficiency of all the iron stores. Okay, the ferritin levels will be down. The serum iron or the free iron will be reduced. TIBC will be increased. Okay, but the saturation will be decreased, because the iron is not in the body, right? Even though you are increasing the TIBC or the transferrin levels or the saturation or the affinity of the transferrin, still you have the low iron, and that's why the saturation of the transferrin will be severely decreased. In case of anemia of the chronic disease, okay, you will be having a low serum iron, because all of the iron will be sequestered in the macrophages and the bone marrow, right? So you will be having a high ferritin levels, but low serum iron. Apart from that, you will have a low TIBC, because the iron stores are full. So saturations, so the affinity of the transferrin will be decreased. That means the TIBC will be decreased. For the saturation, you will either have a normal saturation or the low saturation. For the hemochromatosis, in which you are having an iron overload, you will be having a very high ferritin stores, okay, and as well as a free iron in the serum, okay. Plus, you will have a low affinity of the transferrin for the iron, or the levels of the ferritin will be or the levels of the transferrin will be low, okay, and you will have a very high saturation, because lots of iron is available for the binding to the transferrin. So the transferrin will be saturated with the iron, right? Very high saturation. In case of OCP use or the pregnancy, you guys know, because of the estrogen, every transported protein will be increased. Okay, every carrier protein will be increased in your body. As a result, the transferrin also will be increased. Okay, and when the transferrin is increased, the saturation will be decreased, because you have more transferrin than the iron available, right? So less iron will be binding to the transferrin. Okay, so we'll have a low saturation. Is that okay?
Yes.
So yeah, that's everything about the interpretations. So always look for the ferritin count. For the TIBC, they will always oppose it, and look for the serum iron. If you have a deficiency, serum iron will be low. If you're having a hemochromatosis, the serum iron will be high. In case of chronic diseases, you will have a low ferritin, you will have a high stores, but a low serum iron. Very important to know. Then comes the macrocytic anemias. in which you have a MCV levels more than 100 femtoliter. Okay. First one are the megaloblastic anemia. The hallmark feature of the megaloblastic anemia is the MCV more than 110 femtoliter. Whenever a question stem describes the RBCs having the volume more than 110 femtoliter, that means they're talking about the megaloblastic anemia. Because in case of only the megaloblastic anemia, you can have a MCV more than 110. Rest all other causes of the macrocytic anemias, you will having a volume between the 110 to 100. Okay. Okay, so it is because of the impaired DNA synthesis, right? You will have a loss of maturation of the precursor cells. As a result, the size will be very much increased already, because as the cell matures, as the RBC matures, the size of the RBC will be decreased, right? But because the DNA is not available, so the maturation won't happen, and as a result, the size of RBCs will be very much large. Okay, and the causes includes a vitamin B12 deficiency, the folic acid or the folate deficiency. Okay, certain medications which can inhibit the nucleotide synthesis, like the hydroxyurea, like the phenytoin, methotrexate, other sulfur drugs, they all can cause the megaloblastic anemia. Okay, in which you're having a loss of nuclear maturation, I must say. Okay, so the findings include the RBCs, which are macrocytosis in this case, as well as the hypersegmented neutrophils. These are the hallmark feature, the hypersegmented neutrophils along with the macrocytes that you will see in the megaloblastic anemia. Okay. In case of folate deficiency, the causes include some malnutrition, okay, which could be seen in the alcoholics, okay, or sometimes with the malabsorption syndromes, right? And you can see them with the drugs like the methotrexate, like the trimethoprim, okay, and the pyrimethamine also, right, which is an anti-parasitic drug. You can see them with the phenytoin also, right? And sometimes in case of pregnancy, because of the increased requirement, you can also have the folate deficiency, right? And yeah, these are all the causes of the folate deficiency, right? And what are other things you will see? You won't see any neurological symptoms in case of folate deficiency, and the folate stores in your body is about 6 to 9 months, right? So deficiency of the folate will be seen within 6 to 9 months of the cause, right? So, and there won't be any elevated levels of the methylmalonic acid, unlike in case of vitamin B12 deficiency. And because the methylmalonic acid levels are absolutely normal, you won't have any neurological symptoms. Okay, although you will have a high level of homocysteines, right? You guys remember this part of homocysteine? From the homocysteine urea, we have discussed the causes, the vitamin B6 deficiency and the vitamin B12 or B9 deficiency, right?
Yeah.
Yes. And why you have this high level of homocysteine in case of vitamin B9 deficiency?
It cannot be converted into methionine.
Yes, exactly. That's why. Okay, so, and please remember that the folate is in very high amount in the vegan food, right? So for the vegan food, you cannot suspect the folate deficiency, right? Mainly these are the alcoholics ones uh, or the patients on these kind of drugs like the methotrexate, trimethoprim, pyrimethamine, or the phenytoin, right? Suspect the deficiency only in these patients. And the symptoms will be visible after 9 months of the cause or the initiating factor, right? Because your body has a 6 to 9 months stored for the folate. Then comes a vitamin B12 deficiency. You will suspect the vitamin B12 deficiency only after 4 to 6 years of the cause. After the inciting factor, only after 4 to 6 years, you can have the vitamin B12 deficiency. Causes includes a pernicious anemia. It could be a patient with a history of a chronic gastritis or the autoimmune gastritis for more than 4 years. Then they can have a vitamin B12 deficiency. Okay, it could be a malabsorption, like in case of this pancreatic enzyme deficiencies, like the chronic pancreatitis, like in case of Crohn's disease also, like in case of this tropical spur. Okay, you can have a deficiency of vitamin B12, right? Gastrectomy, because in case of removing your stomach, then you will be removing the parietal cells, and as a result, the vitamin B12 will be lost, right? And you can also have because of the insufficient intake, like in case of veganism, because the animal protein is a very good source for the vitamin B12, but not the but not the plants, right? You can have the presence of these tapeworms like the Typhlobothrium latum, which will feed on your vitamin B12 resource. So no matter how much intake of the vitamin B12 you will get, you will always get a deficiency of it in case of these parasites. Okay, so remember the pernicious anemia and gastrectomy, malabsorption, which includes the Crohn's disease and the pancreatic insufficiency, insufficient intake because of the veganism, and the Typhlobothrium latum because of they will compete for these stores. Okay, you will have the high level of homocysteine as well as the high level of methylmalonic acid, and because of this high level of methylmalonic acid, which is kind of very toxic to your neurons, you can have the neurological symptoms, which is known as a subacute combined degeneration. Okay, and yeah, you will have the damage to the spinocerebellar tract. Okay, the lateral corticospinal tract, which is for the movements, your muscle movements. Okay, spinocerebellar tract for the balancing, right? And the dorsal columns for the sensory functions. So you will have the sensory function loss, you will have the ataxia, you will have the paralysis also. Okay, and the this anemia symptoms, okay, which is fatigue, pallor, and all these things, they will be kind of reversible if you give the patient vitamin B9. Okay, but the neurological symptoms, they cannot be reversed after giving the vitamin B9, right? They will still be there. Very important to note. So if you give the patient folate supplement in case of vitamin B12, they will reverse the anemia, okay, but it will also worsen the neurological symptoms. Okay, sling test is a primitive test that you used for the vitamin B12, but it is not very much used nowadays. Okay, and yeah, if you have anemia because of insufficient intake or because of malabsorption, then it would take at least 4 to 6 years to develop the vitamin B12 deficiency. Okay, so any doubt on it?
No, thank you.
Can you
Yeah,
explain the folate trap mechanism?
can I explain the
Like, how does the symptoms get worsened with the supplementation of folate?
see, because you are
In
giving the
B12.
patient folate supplements because see, once a patient with the vitamin B12 deficiency comes to a department and you suspect it to be a B9 deficiency, not a B12. So you're not giving any kind of treatment for the vitamin B12, right? You have given the patient vitamin B9, and as a result, the anemia of the patient is corrected. You still have no idea that the patient is having a vitamin B12 deficiency. Okay, so you are just giving, you are just improving the anemia of the patient. Okay, not doing anything for this for the neurological damage. The levels of the methylmalonic acid will keep on rising, and they will keep on damaging more neurons, right? And as a result, if you give the patient vitamin B9, they will mask the symptoms of the anemia. You think the patient is now corrected. Okay, he has been treated, but eventually they will get the high level of these acids and they will get the high damage because of it. So it's just like because you're kind of avoiding the vitamin B12 treatment, right? That's why you have this kind of thing. It's just because you're not
So,
giving any supplements.
okay, I got your point, but I was thinking it is because of folate trap, like vitamin B12 gets converted into, no, sorry, supplementation with folate can increase the synthesis of other substances instead of methylmalonic acid.
See, methylmalonic acid has nothing to do with the vitamin B9. It has a different path, right?
Yeah,
So
it
methylmalonic
is
acid has nothing to do with the B9.
or
It just,
fatty acid.
yeah, it's just the fact, that you're kind of avoiding the vitamin B12 for the treatment whole time. You're just focusing on the vitamin B9, and the vitamin B12 will be keep on become deficient in the body. That's why you're having this worsened symptoms.
Okay.
Okay.
Okay. Yeah. Okay. Thank you.
I have one question.
Yes.
In subacute combined degeneration, like when we call a disease subacute combined degeneration, does it
Yes.
involve all those three columns, or is spinocerebellar tract not a part of subacute combined degeneration?
Sorry, I didn't understand the question.
Okay, I'm saying that subacute combined degeneration of the spinal cord, it includes degeneration of all those three columns or only of the lateral corticospinal tract and the dorsal
All
column?
of three columns. All of three columns.
Okay, okay. Okay, thank you.
Yes.
Yeah, thank you.
So, any more doubt? Any more doubt? And yeah, please remember that in case of vitamin E deficiency, and as well as in case of one disease, which is, can someone tell me? Friedreich's
Can you repeat
ataxia.
what?
Don't worry. In case of vitamin E deficiency, as well as in case of Friedreich's ataxia, you will get the similar neurological symptoms, a subacute combined degeneration. Okay. So be
But you
careful
get
while choosing.
hemolytic
Yeah. So be careful while choosing
and
the vitamin B9 and the B12 as an option. Okay. It depends upon the patient history. Okay. If he's having a gastrectomy, okay, or if he's having this celiac spurt thing, then he can have a vitamin E deficiency. If he's having a gastrectomy completely, or this Crohn's disease or any involvement of the ileum, okay, stomach involvement or the ileum involvement, you will mainly choose a vitamin B12 deficiency. Other site involvement, okay, you will choose a vitamin E deficiency, and it is also dependent upon the time. If the patient is having a history less than 4 years or 3 years, that means he cannot have a vitamin B12 deficiency. It must be the vitamin E deficiency which is causing these symptoms, right?
Yeah.
So history of the patient will be very important while selecting the option. So be careful, because vitamin B12, and as well as vitamin E, they both can have a neurological symptoms, which is subacute combined degeneration. And same thing goes for the Friedreich's ataxia. You can have the neurological symptoms very similar to them, but you will have the other features like the hypertrophic cardiomyopathy or this diabetes, right? Or the food changes, but they will help you choose these disorders. Okay.
Yeah.
Okay. Then comes the orotic acid urea, in which you are having a deficiency of UMP synthetase. Okay. And as a result, the orotic acid levels will be keep on rising, right? And they just cannot be converted into the UMP. Okay. So as a result, the synthesis of the nucleotides will be inhibited, right? And what you will have is the megaloblastic anemia. Okay. So symptoms will include the failure to the thrive because you're having a loss of nucleotides, right? Developmental delay could be there. Megaloblastic anemia would be there. Okay. And the high level of orotic acids will be there, which will come into urine. Okay. And you will detect the high level of orotic acids in the urine, that's why the disease is known as the orotic acid urea, right? But you do not have any hyperammonia. See, in case of a ornithine transcarbamylase deficiency, you can still have the orotic acid urea, okay, because by default, or the carbamoyl phosphate will be forming the orotic acid, right? So both in the deficiency of ornithine transcarbamylase as well as a UMP synthetase, you can have the orotic acid urea. But in case of the UMP synthetase deficiency, you are having the orotic acid urea along with the megaloblastic anemia. But in case of ornithine transcarbamylase deficiency, you will be having the orotic acid urea along with the hyperammonia. Okay, these two things are very important in differentiating the causes. Okay, so what is the treatment? You will give the patient uridine monophosphate or the UMP synthetase enzyme replacement. Okay, either you can give a direct supplement of this uridine monophosphate, or you can give the enzyme supplements to the patient. That's how you can correct the orotic acid urea. Is that okay?
Yes.
Now comes the non-megaloblastic type of anemias, in which you are having a macrocytosis but not a megaloblastic anemias. Okay, which means you'll be having a very large size of the RBCs but less than 110 femtoliter. Okay, and without the hypersegmented neutrophils. Okay, the causes includes any kind of liver disease, which could be due to the alcoholism, could be any other liver disease also, and sometimes could also be seen with the hypothyroidism. Okay, other cause includes a diamond blackfans anemia. Okay, and please remember, these symptoms are very important for that. Okay, you will have the craniofacial abnormalities. Okay, a triphalangeal thumb would be there. Okay, generally you have two phalanges only for the thumbs. Okay, but if you have three phalanges in the thumb, that means it is kind of an example. That means the patient is of the diamond blackfan syndrome. Okay, and Yeah, the patient will also be the short stature. Okay, they will have a total of loss of hemoglobin, but the percentage of the of the fetal hemoglobin will be increased, of course, right? And yeah, it would be evident within the first year of the life. Okay, nothing much more about this syndrome. Just remember three things: the craniofacial abnormalities, and this tripharyngeal thumb is very important. Whenever you encounter this tripharyngeal thumb, that means they're talking about the Diamond Blackman syndrome, and they will tell you the size of the RBCs, which is less than 110 but more than 100 femtoliter. Okay, and on the PBS you won't see any kind of hypersegmented neutrophils. Okay, and this disease will be evident within first year of the life. Is that okay?
Yeah, okay.
And so in order to correct any of these disease, if you give the patient enzyme supplement or the vitamin supplement, okay, then what's gonna happen? All the immature cells will be released in the blood. Okay, all of, because uh, in all of these scenarios you will be having a low reticulocyte count, because your bone marrow do not have these supplements properly for synthesis of these RBCs, right? So whenever you give the supplements, your bone marrow will become suddenly activated, and all of the immature cells, the nucleated cells or the reticulocytes, they will be released in the blood at a very early stage. So what you will see is a very spike of the reticulocytes as soon as you give the patient these supplements. Okay, then the spike will fall and the level of the RBCs will be rising very slowly. So if I annotate it, I draw the graph. Okay, this is the levels of the cells and this is a time. Okay, initially you will be having a very low level of reticulocytes, which is here, and a low level of RBCs, which is here, right? And when I give the enzyme supplement here or the vitamin supplement here, what you will see a very spike in the reticulocytes in the blood. Okay, and these cells will start and then these cells will start converting into the matured form. So the levels of the reticulocytes will be decreasing. It will come to the normal again, right? But the levels of the mature RBCs will be rise very slowly, like that. It will take so much time to get into the normal level. Is that okay?
Yes.
So step one will ask you why this spike is happening after giving the patient supplement. It is because of the release of immature cells from the bone marrow suddenly when the bone marrow get activated. Okay, if you give the iron supplement, the vitamin supplement, or any kind of supplement or the enzyme therapies, you can see this thing. Okay, you will see the peak within 3 to 4 days. Okay, and after 1 week the peak will start kind of decreasing. Okay, but the anemia will take around 1 to 1.5 months to correct after giving the these supplements. Very important to note. Any doubt on this page?
Could you please explain why the immature cells are being released after the therapy is given?
Because of, see, when when you have the deficiency of all these supplements, the vitamins or the enzymes, your bone marrow will be active, will be inhibited, right? It
Yes.
won't be responding. The level of the reticulocytes will be very much low, along with the anemia, right?
Yeah.
Because our bone marrow do not have any kind of supplement to the synthesis of these RBCs. But as soon as you give the bone marrow supplement, it will get activated, right? And
Yeah.
now
Yeah.
it will try to compensate for the anemia. So
Okay.
whatever
Okay.
cells it has reserved in it, it will release them
Okay.
as soon
Yeah,
as
I
it
got
gets
it.
activated.
Yeah.
Yes.
Thank you so much.
So please note the spike is not of the matured RBCs, but the spike is of the immature RBCs or the reticulocytes or further more immature forms. Okay, but after 1 week, the spike will be keep on would decreasing, and the levels of the mature RBC will be rising very slowly, and it will take around 1 to 1.5 months to correct the anemia completely, around 8 weeks. Okay, very important to note. Okay, so we have discussed the microcytic type of anemias, we have discussed the macrocytic type of anemias, and now comes the normocytic normocronin type of anemias. And we have discussed the causes. Either it could be a non-hemolytic type or it could be a hemolytic type. Okay. Okay, so the hemolytic type of anemia will be further classified according to the cause of hemolysis. If it is an external cause or if it is an internal cause, we have discussed. Okay, for the internal cause, we have discussed the enzyme defects, okay, the membrane defects, right? For the extrinsic cause, we have discussed about how these antibodies can attack the cells, right? And other things also. Now, in all of these scenarios, you will have the high LDH count because you know that LDH is a marker of cellular destruction. In any disease, whenever you're having a cell destruction like the infarction or necrosis, you will always have the high LDH. Similarly, in case of this hemolysis, you will be having a high level of LDH. Okay, the bone marrow will be responding to them, to that hemolysis, and as a result, the reticulocyte count will be rising. Okay, you will get the unconjugated bilirubin levels will be very high. Okay, because of the rapid hemolysis. What you can get is the pigmented gallstones. Okay, the urobilinogen levels in the urine will be rising, and please note it is urobilinogen, not the conjugated bilirubin. Okay, both are different things. Okay, the urobilinogen will be only formed when this conjugated bilirubin enters the GI tract and it become
Stercobilin.
stercobilin. Okay, and this stercobilin will convert it into the urobilinogen in the kidney. Okay, so these are the common for both the intravascular as well as the extravascular hemolysis. Okay, now the site of hemolysis depend upon whether the hemolysis is happening within the blood vessels or outside the blood vessels, like the spleen or the liver. Okay, if the hemolysis is happening in the spleen or liver, you will call it an extravascular hemolysis. If the hemolysis is happening within the blood vessels, you call it the intravascular hemolysis. Okay, these things, the increase in the LDS at the reticulocytes, high level, the unconjugated bilirubin, and the stones and the urobilinogen, it is common for both these hemolysis, right? But in case of intravascular hemolysis, you will also get the low level of haptoglobin. Because of the destruction of RBCs, all of the hemoglobin will be released in the blood itself, right? And this hemoglobin must be taken to the spleen or to the liver, to the macrophages, so that it could be destructed and and it could become the bilirubin and the substances, right? So the level of the haptoglobins will be decreased. Okay, you can also expect a cystocytes on the blood smear. Remember the helmet cells because of the intravascular hemolysis, because of this microthrombitis. Okay, so you can expect the cystocytes in the blood smear. Okay, you will also get the hemoglobin urea because the hemoglobin is being released in the blood vessels. They will go to the kidney, okay, and they will release the hemoglobin in the urine. So that will cause the hemoglobin urea. Okay, so you will have a hematuria type. You will have a very reddish urine, right? And you can also have the hemocytin urea, okay, as well as a urobilinogen in the urine. Okay, and because this hemoglobin urea and the hemocytin urea, you can also have the kidney damage because they contain the iron, right? And this iron can cause the this free radical damage, right? So you can also have the kidney damage because of it, right? And the causes includes any kind of mechanical hemolysis, like in case of any prosthetic valve or in case of any microthrombi, for example, the microangiopathic hemolytic anemia or the macroangiopathic hemolytic anemia, right? You can also get into paroxysmal nocturnal hemoglobin urea, right, in which you have a complement activation within the blood vessels and they will destruct the RBCs, right? So please remember the decrease in the haptoglobin and the cystocytes. These are the two important things which you will get in the intravascular hemolysis. You will get the kidney damage because of hemoglobin urea. Then comes the extravascular type of hemolysis, which is happening in the spleen and in the liver. That's why you will have a normal level of haptoglobin. Okay. Sparocytes will be seen in the peripheral smear. We have discussed that already. You will have the sparocytes, you will have the reticulocytes count very much high. You can even have the nucleated RBCs in the peripheral blood smears. Okay. This could be seen with the hydrated parasitosis or the autoimmune hemolytic anemia also. Okay, you won't have any hemoglobin urea or the hemocytin urea because this hemoglobin or the hemocytin will be destructed in the macrophages and they will be converted into the bilirubin, right? So you won't have any hemoglobin urea. Okay, and but you do have the urobilinogen in the urine because you will be having a high level of bilirubin. So this will be converted into a urobilinogen that will come into the urine. Okay, splenomegaly will be present. Why? Because all of the macrophages in the spleen, they will be destructing the RBCs. They will engulf the RBCs. right? And so you can have the splenomegaly also, the red pulp expansion. Is that okay?
Yeah.
Good. Just give me a second. Okay. So let's discuss the non-hemolytic causes of the normocytic anemias. The first one is and in all these causes, your bone marrow is kind of not responding. Again, you will have the low reticulocyte count in these disorders. Okay. First comes the anemia of chronic disease. Whenever you have any kind of chronic disease, for say the obesity, the diabetes, right? Any kind of autoimmune disease, any kind of cancer, right? The chronic kidney disease or anything. Okay. Whenever you have any chronic disease, you will have the iron dysregulation because of release of hepcidin, right? Hepcidin will make sure that no cell in the body, the bacteria or even our own body cells, they can feed on the iron, right? So as a result, you will have the sequestration of the iron, right? And because of the sequestration, you will have the high iron levels in the body. Overall, you will have a high iron stores, which means the ferritin levels will be very high in the macrophages, right? These macrophages are present in the liver, in the spleen, in the bone marrow. So whenever you look for the iron levels or the iron stores in the body, in the bone marrow, you will have a very high iron stores, right? But the body cells cannot feed on them. Okay, your bone marrow cannot utilize it, and as a result, you will have the anemia. So because of inflammation, you will having a high levels of interleukin 6, which will release the hepcidin that will bind to the ferroportin, right? And it inhibit the transport of the iron within the blood from the enterocytes. Okay, it will also activate the macrophages to cause the inhibition of the transport and causes the increase in sequestration of the iron within the ferritin, right? The iron absorption will also be decreased. It will be associated with with any kind of chronic infection, any kind of neoplasia, any kind of chronic kidney disease, autoimmune diseases like the SLE, rheumatoid arthritis. It could also be seen with the chronic heart failure or with the obesities. Okay. You can also have the elevated porphyrin levels because you guys know that the iron and the porphyrin will combine to form the heme. If the iron is not there, then you can also have the elevated porphyrin levels in it. Okay. The free iron levels will be decreased. The ferritin levels will be very much rising. The storage, right? So you will have a low TIBC. Very important. At the very initial times, you will have a low level of hemoglobin, which is kind of less than 8. Okay, but even though you're having a very low hemoglobin, you will have a normal size of the RBC. Okay, around 90 to 100. And that shows that the patient is having an anemia of chronic disease. While in case of iron deficiency anemia, right, you will have a very low level, a very low volume of the RBCs, which is less than 80 when you have the hemoglobin level around 8. Okay, so just remember, whenever you have this anemia of chronic disease, you will be having a anemia. The hemoglobin levels are falling around 8. Even at the hemoglobin level 8, you will have the normal size of RBCs. But in case of iron deficiency anemia, you will be having a very small size, more less than 80 or less than 70 at this 8 gram per deciliter. So you can remember this reference value, and you can imagine what kind of size will be present in case of anemia of chronic disease. Right? Treatment includes erythropoiesis. Okay. It includes the agent giving the patient erythropoietin EPO in case of the chronic kidney disease, because in case of chronic kidney disease, it is the kidney from where you have released the EPO. And if the kidneys become dysfunctional, then in that case, the EPO will be deficient, right? You have to give the patient EPO also. And it is seen that in case of anemia of chronic disease, even though you are having a high levels of EPO, but they are not enough. Okay, these levels are lower than what could be expected at this kind of anemia. Okay, so you have to give the patient erythropoietin in case of anemia of chronic disease so that you can activate the bone marrow. Okay, you will still have the low level of reticulocytes. Okay, so if they do not give you the values of the iron in the body, they will just tell you, this low level of EPO or low level of the reticulocytes. Okay, and the size of RBCs will be there along with the hemoglobin levels. So based on these information, you need to identify whether the patient is having the iron deficiency anemia or the anemia of chronic disease. The only way you can recognize it by this reference value, you will think about the 8 gram per deciliter. At this level, if you have a normal size of the RBCs, Okay, that means it is an anemia of chronic disease. If you're having a very small size of the RBCs, that means it could be the iron deficiency anemia. Okay, the levels of the reticulocytes will be low in both of these conditions. Because is that okay?
Yes.
Okay, then comes the aplastic anemia. Okay, in this kind of anemia, you will be having a replacement of the normal bone marrow tissue with some kind of a fat or other tissues, right? And as a result, with the aplastic anemia, you will have the pancytopenia always. See, the aplastic crisis is a different thing. In case of aplastic crisis, you will be having a loss of RBCs only. In case of aplastic anemia, you will be having a loss of all the cell lineages. So you will be having a pancytopenia. Okay. The causes includes the radiations, okay, drugs like the benzene, like the chloromphenicols, alkylating agents, or any other chemotherapeutic agent. Okay, they will cause a destruction of the bone marrow. They will cause the bone marrow suppression. They will cause this pancytopenia. Viral causes, it includes the Epstein-Barr virus, HIV, and the hepatitis virus. Very important. These viruses can cause the aplastic anemia. Other symptoms includes the Fanconi's anemia, okay, which is a defect in the DNA repair. Okay, then the homologous rejoining defect, and as a result, you will have a loss of repair of the DNA damage. The cells will undergo the apoptosis, right? You will have the bone marrow failure. Okay, you will have the normocytosis or sometimes some macrocytosis on the peripheral blood smears. Okay, other causes include the idiopathic ones, which are the immune mediated, and these are the most common type. You have the autoimmune destruction of the bone marrow, right? And please note that it is CD8 mediated, very important to note. It is a type of T cell response and it is CD8 mediated response. You will have the autoimmune destruction of the bone marrow. And because of that, you can also have the aplastic anemia. So on the biopsy, you will see only the, the T cells or the lymphocytes, okay, in the biopsy. So you will know that the patient is having an autoimmune destruction. Okay. Other things you can have is the replacement of this bone marrow with the fatty tissues. Okay, you will see these fats, and in between the fats, you will have the normal bone marrow, which is this part. This is a normal bone marrow, and this is all the fatty replacement. Okay, because the bone marrow is not there, you will have the low level of reticulocytes. You will have the high level of EPO because the EPO will be released from the kidneys in order to maintain the level of RBCs. Okay, so it will stimulate the liver it will stimulate the bone marrow to form more RBCs, right? So high level of EPO is a very hallmark for that. You will have the pancytopenia, right? You will have the normal morphology of the RBCs, okay? But you will have the hypocellular bone marrow, very important. And this hypocellular bone marrow is known as the dry tap, okay? You will have the dry tap because of this hypocellular bone marrow. Symptoms include the signs of anemia, of course. You will have the fatigue, malaise, pallor would be there, right? Because of the loss of platelets, you can have the petechial rash. Okay, you will have some kind of a bluish type of rash and the mucosal bleedings, like the nose bleeding or the gum bleeding. Okay, because of loss of neutrophils and other WBCs, you can have the history of recurrent infections also. So, recurrent infections along with the petechial rash, with fever, fatigue, and pallor, that means we are talking about the aplastic anemia. Okay. And please remember, in case of vitamin B12 deficiency or the B9 deficiency or this orotic aciduria, you can still have the pancytopenia, right? Because these disorders just not only affect the RBC's maturation, but other cell maturation also. Okay. So pancytopenia with the aplastic anemia as well as the deficiency of vitamin B9, B12, and orotic aciduria. Treatment, it includes a removal of the offending agent. Yeah. So the treatment includes a removal of the offending agent. Okay. In case of autoimmune destruction, you will give the patient immunosuppressive therapies like the cyclosporins. Okay. You have to do the bone marrow transplantation, right? You will have to give the patient more erythropoietin, more GM-CSF. Okay. So that whatever the remaining of the bone marrow is there, it can be stimulated more, right? You will have to do the patient RBC transfusions or the platelet transfusions also, right? So these are all the treatment for the aplastic anemia. right? And yeah, because all of these cells, the progenitor cells, are being destroyed in the bone marrow, they cannot migrate to the liver or the spleen for the extramedullary hematopoiesis. So you won't have any hepatosplenomegaly in case of aplastic anemia. Very important to note. Okay, you won't have any extramedullary hematopoiesis in case of aplastic anemia. This is also important thing. So you will have the pancytopenia without hepatosplenomegaly. You will always think about the aplastic anemia. While in other cases, you will have the this hepatosplenomegaly because of extramedullary hematopoiesis. Okay. In case of vitamin B10 deficiency or the B12 deficiency, also you can sometimes expect this uh, hepatosplenomegaly because of this extramedullary hematopoiesis, right? Because the cells were still there, the progenitor cells were still there. But in case of aplastic anemia, because all of the cells are being destroyed, so you won't get any migration, you won't get any kind of hepatosplenomegaly. Is that okay?
Yeah.
Yes.
If you guys remember the case of this hairy cell leukemia, you will have the pancytopenia in that also. Okay, but along with that, you will also have this splenomegaly in it, right? So you sometimes can confuse this aplastic anemia with the hairy cell leukemia also. But just remember, in case of this hairy cell leukemia, you will have the splenomegaly. But in case of aplastic anemia, you won't have any kind of organomegaly, right? Along with the dry tap, because this dry tap will also be seen with this hairy cell leukemia. Remember it, right? The dry tap and the loss of any kind of lymphadenopathy, along with this splenomegaly. These are the symptoms of this hairy cell leukemia, right? So they can mimic the symptoms of aplastic anemia, but just look for this hepatosplenomegaly thing. Is that okay?
Yeah.
Yes.
Okay, then comes the pure red cell aplasia, or you can call it the aplastic crisis. Okay, it could be seen with the thymoma, because this thymoma will destroy all the RBC's progenitor cells. Okay, similar thing could also be seen with this parvovirus B19 infection, right? So whenever you have an infection with the parvovirus B19 or you have the thymoma, you will have the destruction just the RBCs only. Okay, and you can have this pure red cell aplasia. Remember these two causes. Okay, so you will have a low level of hemoglobin, you will have a low level of reticulocytes because the progenitor cells won't be there to replace these RBCs, but you will have a normal iron levels. Okay, iron studies will be absolutely normal. The ferritin was normal, the TIBC was normal. Okay, and this normal, the serum iron will also be normal, right? But you have the low hemoglobin and the low reticulocyte count. Okay, is that everything? Okay.
I have one question.
Yeah.
Pure red cell aplasia and aplastic crisis are the same thing.
Yeah.
Okay, got it. Thank you.
Normal iron, because you're not interfering anything, anything with the iron, right? It's just you're having a normal iron
Yeah,
means
right.
normal iron. Yeah. Okay. Any doubt on this page?
No, thank you.
So remember this point, very important to differentiate between the iron deficiency anemia and the anemia of chronic disease, that even at the level of hemoglobin less than 10, you will have this microcytes in case of iron deficiency anemia, right? But in case of anemia of chronic disease, it would be normocytic type. This will help you determining between differentiating between these two disorders. Now the hemolytic type of normocytic anemias. Okay, and first we discuss about the intrinsic type of hemolytic anemias, which means a defect is within the RBCs itself, right? And first one is the membrane defect, right? The membrane defect include the hereditary spherocytosis, which is an autosomal dominant condition, which means both the male as well as females could be affected with this disorder, right? You have the membrane defect, okay, and some proteins are present in the RBC membrane, like the ankyrin, spectrin, okay, band 3, and the protein 4.2. Okay, these are some proteins which are involved in the stability of the plasma membrane. Okay, but once you get the mutations in these proteins, what you will get is the instability in the plasma membrane, and the RBC membrane will become very much fragile. Okay, you will have the small RBCs, you will have the round RBCs with less surface area. okay, and no central pallor is there. The mean corpuscular hemoglobin concentration will be increased because of this small size of the RBC. The hemoglobin concentration will be increased. Okay, the premature cells will be removed by the spleen, of course. So you will have the extravascular hemolysis because these cells are kind of defective type. Although they are having a normal transport of the iron, the oxygen. Okay, they are working fine, but they have this round shape and this abnormal kind of cells. So that's why they will be removed by the spleen. Okay, so the treatment that you can give the patient of hydatidispyrocytosis is to remove the spleen, because this anemia thing is because of the spleen only. So if you remove the spleen, the anemia could be corrected. Okay, so you do the splenic surgery, the splenectomy, for the treatment of the hydatidispyrocytosis. Okay, please remember, you will have the hyperchromia, or the high concentration of the hemoglobin. That's why you will have the high MCHC. Okay, the patient will have a less surface area. Okay, and the small size also. Splenomegaly will be there because of the destruction of these RBCs within the spleen. The red pulp will be increased. You will get the aplastic crisis if you have the infection with the parvovirus B19, because the cells are kind of rapidly destroying, right? So they have a short life. Okay, and as a result, they need to be replaced very soon. If the parvovirus B19 infection happened, then the erythropoiesis will be halt. Okay, and the remaining RBCs will be destroyed very early stage. So you will get the aplastic crisis. Okay, any kind of infection or any kind of stress, like we have discussed, the fasting or this psychological stress or any kind of illness, they can trigger the hemolysis in the cells. Okay, they can trigger the hemolysis and the patient can have acute episodes of the jaundice or this fatigue. So it can also mimic the what disorder? We have discussed it already in the GI section about the liver. Deficiency of which enzyme?
Rotor.
Rotor? No. The Gilbert syndrome, okay? Symptoms can mimic the Gilbert syndrome, but you need to identify the level of the conjugated and the unconjugated bilirubin, right? Both levels will be rise in case of hydatidispyrocytosis. Okay. Okay, you can do the eosin 5 melanamide test. Okay, EMA test you call it. Okay, increase in the fragility, which means you will place the RBCs in the high osmotic gradient or the low osmotic gradient, and then you will check if the RBCs are being destroyed. Okay, and what you will find is the normal to decreased mean corpuscular volume, because we know that the small RBCs are there. Okay, so MCB could be reduced and you will have the high level of MCHC. Okay, and you will also have the spherocytes in the peripheral blood smear. Okay, so that's everything about the hydatidispyrocytosis. Okay, and all of these cells, because they are keep on destroying and they must be replaced with the new cells, right? So bone marrow has to produce more cells. That means more amount of these nucleotides are required by the body, right? And as a result, the requirement of the folate and the vitamin B12 is increased in these kind of patients, like we have discussed. Okay, and if you do not give the folate supplement or the vitamin B12 supplements to these patients, the patients can also get the megaloblastic anemia. So if you encounter a case of patient with this hemolysis along with the megaloblastic anemia, that means it is because of the deficiency of the these B9, because the requirements are increased. Is that okay?
Yeah.
So do remember these facts also. Because of this rapid destruction, these cells need to be replaced very soon. So you can get this megaloblastic anemia also. Okay, then comes the glucose 6 for, sorry, just skip that for now. Then you have the paroxysmal nocturnal hemoglobinuria, which is again a membrane defect, okay, in which you have a loss of this glycoprotein, okay, which is an anchor protein. Okay, it will anchor the DAF and the MERL with the RBC's membrane, and this DAF and the MERL are responsible for the inhibition of the complements against the RBCs. Okay, you have the mutation in the PIGA gene, which synthesizes the GPI type of this glycoprotein, the anchor protein. If you have a mutation in the PIGA gene, then this glycoprotein will become mutated, and as a result, the DAF and MERL will be lost. Please remember the CD markers for the DAF and MERL. They sometimes won't give you DAF or MERL. They will give you the CD markers instead. Okay, so these are the CD55 and the CD59 markers. Okay, you will have the loss of these markers from the cell, and as a result, now the complements can get activated against RBCs and other body cells like the neutrophils or other WBCs or the platelets. So what you can have is a pancytopenia because of this complement destruction. Okay, and generally the complement destruction happens in the night time because in case of night time you will have a high CO2. Okay, and this high level of CO2 will activate more complements, right? So you will have a more complement activation in the night, so more destruction, more hemolysis will occur in the night, and the hemolysis will be of intravascular type. So you will have the hemosiderin in the urine, you will have the hemoglobin in the urine, so this will give the urine a red appearance. Okay, so when the patient woke up in the morning, they will have a very this red urine or the hematuria. They will complain something like that. Because of the hemolysis, the patient can also have the venous thrombosis. Okay, most commonly the Budd-Chiari syndrome, right? You will have the Coombs negative type of hemolytic anemia because the antibodies has no role in it. It's just a complement destruction is there, right? Pink or the red urine will be there in the morning. Okay, you can get the aplastic anemia also. You can also get the acute leukemias, right? Treatment, it includes the inhibition of the complements, especially the complement C5, which ultimately makes the membrane attack complement, the membrane attack complex, right? So you need to inhibit the C5 by giving the patient eculizumab. It is an antibody that targets the C5. Okay, very important. So you will have the pancytopenia, and because the your bone marrow is absolutely normal, right? So bone marrow will try to compensate for this cause, and you will have the high reticulocytes. So a pancytopenia with high reticulocyte count, it is the paroxysmal nocturnal hemoglobinuria. Okay, a pancytopenia without reticulocytosis, it could be the aplastic anemia, or it could be the vitamin deficiency. Is that okay?
I'm not getting it since we have aplastic anemia means the, the precursors are not there. So from where does these reticulocytes coming from
See,
in
it is not always
paroxysmal
the
nocturnal?
it is not always the case that this PNH is associated with the aplastic anemia. It sometimes can, but not always. Okay, in a very later stage of the disease, when these complements can start acting against these your pro- uh, your bone marrow also, then you can get the aplastic anemia at a very late disease. Okay, but not in the early part. So in the
Oh,
early part, you will have the pancytopenia with a normal bone marrow response. Okay.
okay, okay. Thank you. Got the point. Thank you.
Yes. Okay, so you will have the hypercoagulable still because of the RBC lysis. So you can expect the venous thrombotic episodes also. So a patient which will having a complaint of the hematuria early in the morning, okay, along with the pancytopenia, which means the fatigue, pallor, jaundice, and this recurrent infections, the petechial rash, the bleeding, along with the deep vein thrombotic episodes or the Budd-Chiari syndrome, which means the hepatosplenomegaly. That means we're talking about the PNH. Okay, that's how the step one can present you the question of this PNH. Okay, so this is all about the membrane defects. Let's talk about the enzyme deficiencies. Okay, the first is the glucose 6 phosphate dehydrogenase deficiency. Okay, which is an enzyme responsible for the HMP shunt pathway. Okay, without this enzyme, you won't get to synthesize the NADPH. It is an X-linked recessive deficiency, which means only the males will be affected with this disorder, right? And because of the oxidative stress, you will have the destruction of the RBCs, right? And the oxidative stress includes any kind of infection, okay, sulfur drugs, okay, which means and sometimes anti-malarial drugs also. So it could be a patient who is going to some endemic regions for the traveling, right, for the visiting, like in case of an African region or the India or any kind of Asian country. Okay, so you give them the this therapy for the anti-malaria, okay, for the prophylaxis, right? And after 2 to 3 days they will return back to our clinic with this kind of fatigue, pallor, and jaundice, and a low hemoglobin, right? So that's how you know the patient is having a glucose 6 phosphate dehydrogenase deficiency, right? And with any kind of illness, they can have the episodes of the hemolysis, they can have the this jaundice, fatigue again also. So they can also mimic this Gilbert syndrome type, because in that case also you will have the high level of bilirubin after some kind of a stress. Okay, so you can get the back pain, you can get the hemoglobin urea, okay, few days after the oxidative stress, any kind of illness, any kind of infection, or the drug therapy, right? You will have the intravascular hemolysis, so we'll have the hematuria also, right? And what you will see on the PBS will be the Heinz bodies, and Heinz bodies are the oxidized hemoglobin. Now, to remove these Heinz bodies, the macrophages in the liver and in the spleen will bite the cells, okay, and you will see them as the bite cells. So, a bite cells, okay, the bite cell RBCs and the Heinz bodies in the RBCs, these are all the hallmark feature of the glucose 6 phosphate dehydrogenase deficiency. Is that okay?
Yes.
Okay, and so this is the first enzyme deficiency. Second is the pyruvate kinase deficiency. Okay. Someone is asking something. No? Okay. So now comes the pyruvate kinase deficiency, which is an autosomal recessive, because the pyruvate kinase enzyme is not there, right? So the final step of the glycolysis is inhibited, right? As a result, the ATP synthesis is inhibited. Okay, the RBCs will get eventually damaged, and it is an extravascular type of hemolysis, very important. Okay, and what you will see is the increased level of the 2,3-BPG, right? Because you're not, the reaction, which is the conversion of this phosphoenol pyruvate to the pyruvic acid, is inhibited, right? So you will have the backup of all these substrates, right? So we'll have the increased level of 2,3-BPG as a hallmark. Okay, and the affinity of the hemoglobin for the oxygen is also decreased because of the high level of 2,3-BPG, right? And you will have the hemolysis. You will also expect one abnormal shape of the RBCs, and which is anyone remember?
Could you please repeat?
Because of this deficiency, the pyruvate kinase, you will have the hemolysis, and you will have this RBC shape defect. Remember, we have discussed different shapes of the RBCs. What kind of thing you will expect in the RBCs in case of this enzyme deficiency? What shape of the RBC?
Echinocytes.
Not the chenocytes. Spur cells. Remember the projections from the RBCs? Burr cells or the spur cells, right? Burr cells mainly.
Yeah, Burr.
Okay. Don't forget that. Okay, very important. They will give you this PBS where where the RBCs will be having these projections, and they will ask you what could be the case of this patient. Okay, and they won't mention you the pyruvate kinase deficiency. They will mention the hemolysis instead. Okay, so you have to link up all these things. That because of this type of RBCs, there might be deficiency of the enzyme, and because in this enzyme deficiency, you will be having the hemolysis, right? So this will be the answer, the hemolysis, right? And they can also go one more step ahead, and they will ask you whether it is an extravascular hemolysis or the intravascular hemolysis, right? So you just need to know everything about it. Is that okay?
Yes.
So these are the membrane defects and the enzymatic causes. Now comes the hemoglobin causes. First is a sickle cell anemia. I think we should take a break of for 5 to 10 minutes, okay? And then we discuss a sickle cell anemia, right?
Okay.
Yeah.
Yes.
Okay, so for a sickle cell anemia, you have a mutation in the hemoglobin. Okay, you have a hemoglobin which has a beta globin chain. Okay, and this beta globin chain is synthesized by the beta globin gene, right? So, the glutamic acid on the beta globin gene, it will be replaced by the valine. Okay, and this glutamic acid, it has a negative charge, but the valine, as we have already discussed, it is neutral charge. Now, this negative charge on different beta globin genes or the beta globin chains, okay, they repel each other, And as a result, the polymerization of different chains won't occur in a normal hemoglobin. Okay, but whenever this glutamic acid is replaced by the valine, now this negative charge is lost, so the different chains can come closer and can be polymerized. Okay, and that causes the sickling of the RBCs, and it generally happens whenever you have a low oxygen. Okay, like in case of any high altitude, in case of acidosis, okay, in case of any other kind of conditions in which you have a high level of CO2 or low level of this oxygen, they can cause the sickling. Both intravascular as well as the extravascular hemolysis will happen. Okay, and this mutated HbA is now termed as the HbS. Okay, very important. So whenever you have a deoxygenated HbS, it will polymerizes, it will cause the anemia, and all of the symptoms that you will see in case of sickle cell anemia, it is because of the vaso-occlusive crisis. You will have the occlusions of the vessels, like the hands, like the abdomen, feet, or other areas. So you will have the pain in the hands, you will have the abdominal pain, you will have the chest pain, you can have the headache, you can have the this pain in the legs or the claudication type of things, right? So all of the symptoms of the sickle cell anemia are because of this vaso-occlusions. And of course, the anemia symptoms will be there, like fatigue, pallor, jaundice, right? Newborns, they're typically normal up to the 6 months because they have the fetal hemoglobin to prevent them. After 6 months, when the beta chains will become prominent, okay, then then the symptoms will be arise in the patient, right? Very important. And because the malaria requires the RBCs to complete their life cycle, okay, in patients who are having a sickle cell anemia, okay, their RBC will keep on damaging, right? And as a result, the malaria cannot survive on these type of RBCs. Okay, so a heterozygote patient with the sickle cell anemia, or I can say the sickle cell trait, okay, they're kind of resistant to the malaria, right? Very important. Okay. Also, what you can see on the peripheral bed smear are the sickle shaped cells. As you can see, this is a sickle shaped cell. Okay, you can also see the targetoid cells, as you can see. Because of the dehydration, okay, you are having a loss of volume. That means surface area to volume ratio will be increased, and you can expect the targetoid cells in the sickle cell anemia also. Okay, your bone marrow will try to compensate it, and as a result, the bone marrow expansion will be there. You will have the crooked appearance and all this, the chipmunk faces and blah blah things. Okay, doesn't matter, they won't give you that much nowadays. Okay, what you can see is a hepatosplenomegaly. Okay, both due to the this vaso-occlusive thing and because of the extramedullary hematopoiesis also. Okay, very important to know. Because of the intravascular hemolysis, and the hemolysis, after all, you're having this high level of LDH. You will be having a high level of indirect bilirubin also. Because of intravascular hemolysis, you can have a low level of haptoglobin. Okay, you will have the hemosiderin you will have this hemoglobin urea, you can have the kidney damage also, right? So yeah, that would be all about this thing, the basic thing. Now, because of these things, because of the sickling of these cells, ultimately, you will be having the vaso-occlusive crisis, okay, in which you can have the dactylitis, which is a painful swelling of the hands and feet because of the vasal occlusion, this vasal occlusion there, right? You will have a loss of blood supply. You can have the dactylitis. You will have the priapism, okay, which is kind of a ischemic priapism, right? You will have the acute chest syndrome because of a vessel in the chest get blocked, in the lungs get blocked, right? It can cause the respiratory distress, and it will be visible as the pulmonary infiltrates on the chest X-ray. Okay, because of the vessel occlusion in the lungs, you can have the acute chest syndrome, and this is the most common cause of death in case of patients with the sickle cell anemia. So it could be a patient having a symptoms just like the pneumonia, the respiratory distress, the pulmonary infiltrates, the crackles, and all these things. Okay, and the patient can even die because of that. Okay, the patient will have a recurrent history of these kind of pains, right? The patient can also have the avascular necrosis of the femur because of the vessel occlusion, right? They can have a stroke because of that, right? So it could be a patient who is having a recurrent history of the body pain. It could be a pain in the hands, pain in the feet. It could be abdominal pain, right? Because of the organ ischemia. It could be a chest pain. It could be a headache. So a patient with a teen patient or a very early age patient with a recurrent history of such kind of pain, you will always suspect the sickle cell anemia. Okay, and Other than that, the patient can also have the aplastic crisis whenever they have a parvovirus B19 infection, because these cells will keep on damaging the lifespan of the RBCs is decreased. Above that, if you have a halt in the RBC production, then you can have a very profound loss of hemoglobin or the profound loss of this hematocrit, right? You can have the aplastic crisis, in which the hemoglobin level can even go down below the 4 gram per deciliter also, right? So a very low level of hemoglobin would be there. Because of the occlusion of spleen vessels, the splenic artery, you can also have the autosplenectomy, right? And so you will have the atrophy in the spleen. What you can see is the fibrosis, right? Because of a recurrent vaso-occlusion, you can have the fibrosis in the spleen. You can have this loss of cells, loss of size in the spleen would be there. And you can have a Howell Jowell bodies, which are the DNA remnants in the RBCs. Okay, these are the inclusions you will see in the sickle cell anemia. Okay, because the now spleen is lost, okay, the patient will be very much prone to the infections with the capsulated organisms, most commonly the Streptococcus pneumoniae. Okay, other includes the Neisseria meningitis or the Haemophilus influenza. Okay, so increased risk in infections with the capsulated organisms, very much there, right? And yeah, the patient can also have the splenic infarction or the sequestration crisis, in which you have a loss of sequestration, a lots of sequestration of these sickle cell cells, right? So a red pulp can expand, and the patient can even get the splenomegaly, right? And these patients are very much prone to develop the salmonella osteomyelitis. Remember, normally this osteomyelitis is caused by the Staphylococcus aureus, but in case of SCA, the patient can have a salmonella osteomyelitis, very common. Okay, because you guys know, whenever the dehydration in the RBCs is increased, when that means if I place the RBCs in a very high osmolarity medium, okay, like in case of renal medulla, okay, where you have a very high oxygen tension as well as the high osmolarity, in that case the in that case the RBC dehydration will occur. Okay, and because of oxygen tensions, okay, the sickling can also happen in the renal medulla. Okay, even though if you're having a this sickle cell trait, okay, in case of sickle cell trait you will have a normal patient, but in this renal medulla you can even have the this sickling in case of sickle cell trait also, right? So you will have the papillary necrosis because of the vessel blockage in the renal medulla. Okay, and that can lead to the hematuria. Okay, so a papillary necrosis, please remember the cause of renal papillary necrosis, one of them is the sickle cell anemia. Okay, very important to know. On the electrophoresis, you will be having a high level of HBS. You will be having high level of HBF. Okay, if it is a sickle cell trait, then you can have a high level of HbA2. Okay, and some increase and some normal level of HbA also, right? But in case of sickle cell disease, you won't be having any level of HbA1. Okay, you will be having some increased level of HbA2, increased level of HbS, and increased level of HbF, but not the HbA1. Okay, treatment, it includes the giving patient hydroxyurea and the hydration. Okay, hydration is very much important. So step one will give you a patient having a recurrent history of body pains, maybe abdominal, maybe joint pains, maybe the extremity pain. Okay, and they will tell you that after giving the patient hydration, the symptoms were resolved, right? So that's how you know the patient is having a sickle cell anemia. Other thing is the hydroxyurea. It will increase the level of fetal hemoglobin, but at the same time, it is also inhibiting nucleotides, so it can cause the megaloblastic anemia also, right? So yeah, that would be everything about the sickle cell disease. Any doubt?
No, thank you.
Please remember all of these features of the sickle cell anemia. These are the symptoms which you will see, and this is the cause. At one side, this is all the cause. At other side is the symptoms which you will see in the sickle cell anemia. Then comes the HBC disease, in which you have a replacement of the glutamic acid with the lysine, and lysine is a basic amino acid, which means it has a positive charge. Okay, so this disease is kind of less severe than the sickle cell anemia, right? What you can have is the crystals of the HBC. Okay, you have the crystals inside the inside the cells, as well as you will also have the targetoid cells in case of HBC. So whenever you encounter a question in the step 1, okay, having the targetoid cells along with some crystals, that means it is a HBC disease. Okay, targetoid cells without crystals, it could be the sickle cell anemia, but the targetoid cells with the crystals, always the HBC disease. Any doubt on that?
No, thank you.
Okay. So a child with the sickle cell anemia, they will run out of the breath very quickly because of the anemia, because of loss of this oxygen delivery to the patient body, right? They will having a recurrent pulmonary infections. They will have a history of bone pain, dactylitis, or the abdominal pain, or the hepatosplenomegaly. These are all the features of the sickle cell anemia in the child. Now comes the extrinsic hemolytic anemias, in which the RBCs were absolutely normal. Okay, it's just some external factors are causing the hemolysis of the RBCs. The first one are the autoimmune hemolytic anemia, in which you have a formation of antibodies against the RBCs, and as a result, they will cause the hemolysis. Right? Most commonly, these are the idiopathic type, which means they do not have any cause. Okay. Sometimes they could be secondary to some causes also. Right? There are two types. One is a warm type, and second is the cold type. In case of warm, you will be having the IgG antibodies, which will cause the RBC agglutinations. This is the agglutination. See, in case of Rolex formation, you will be having a linear stacking of the RBCs, right? But in case of RBC agglutination, you will be having a clumping of like that. Okay, so please make sure if you won't get any confusion between these two, right? For the RBC stacking, you will think about the high ESR values or the multiple myeloma. For the clumping, you will think about the autoimmune hemolytic anemias, right? So you will be having a formation of IgG antibodies against the RBCs. Okay, you can see this kind of antibodies in the SLE, in the CLL. Okay, along with certain drugs like the alpha methyl dopa, very important. The alpha methyl dopa, which can cause the autoimmune hemolytic anemias, right? And yeah, that would be it. And so because it is a warm type of hemoglobin, this warm type of autoimmune hemolytic anemia, you will have the hemolysis in the warmer part of the bodies, which means the central part, the chest, the abdomen, right? So in these locations, you will be having a hemolysis of the RBCs in the warm locations, right? Now comes a cold type of hemolytic anemia, in which you have a formation of IgM antibodies. Okay, and they will cause the RBC agglutination whenever you expose your body parts to the cold. Okay, that means the earlobes, okay, the extremities, they are generally the colder part of your bodies, which means the cold type of hemoglobin, autoimmune hemolytic anemia, it will affect mainly the earlobes or the colder parts like the hands and the feet. Okay, and whenever you drew the blood sample of the patient and you place them in the ice cubes or any cold area, you will show the clumping. You will see the clumping of the RBCs in it, right? And that's how you know that the patient is having a cold type autoimmune hemolytic anemia. Okay, this condition could be seen with some infections like the mycoplasma, very important. Whenever you have a mycoplasma pneumonia infection, okay, you will have the cold type of autoimmune hemolytic anemia, which means whenever you draw blood sample of these patients with the pneumonia and it show clumping in colds, that means the patient is having a mycoplasma infection, right? You can also see that in the infectious mononucleosis and also with the CLL. Okay, very important. So for the warm type hemolytic anemia, you will think about the alpha methyl dopa, you will think about the penicillins or the cephalosporins. Okay. For the cold type, you will think about the infections as well as the CLL, infections like the mycoplasma or the infectious mononucleosis. Okay, very important. And what you will see in the PBS, you will see the spherocytosis. Like we have discussed, you will see the reticulocytosis. You will see the nucleated RBCs also, right? Treatment includes for the warmer, you will give the patient steroids like the rituximab. Oh, sorry, you will give the patient steroids as well as the rituximab, which is against the CD20 of the B lymphocytes, right? For the cold type, you will avoid the cold, of course, and you will give the patient rituximab. Okay, for the diagnosis, you can do the direct Coombs test or the indirect Coombs test. This also, right? In case of a direct Coombs test, okay, you will be adding the antibodies to the patient. Okay, and if the RBC is agglutinated, okay, that means see, Let us suppose you are having a patient who is having this IgG antibodies against the RBCs, right? So that means in the patient's blood, you will be having this RBCs and the antibodies will be present with the RBCs, as you can see. Now you have to give the patient this, the antibodies against this complex, okay, which is known as the anti-human globulins, which are against the this antibodies in the humans, right? So whenever these antibodies bind to these antibodies, they will show the clumping. And if the clumping is present after addition of these antibodies, okay, that means the patient was having, that means the patient's serum was having these antibodies, right? As well as the antigen, okay? And if the clumping is not there, that means that means the antigen and the antibodies were not present. Then you have the direct womb test, in which you are sure, or you might be sure that the patient is having antibodies. Okay, now you want to test if I give the patient antigen, will the clumping occur? Which means if the patient is having antibodies or not. So I give first the patient donor blood. Okay, let's suppose I want to test the patient for the ABO grouping. I know that the patient is having an anti-B antibodies. That means if I give the patient B type blood group, okay, then I can see the clumping. So what I will give, I will give the patient B type blood group. Okay, now these anti-B antibodies will bind to these RBCs, and now then I add the anti-human globulins, which are against these antibodies. So they will show the this clumping, right? And that's how I know that the patient is having this kind of antibodies, right? If the clumping won't occur, that means the antibodies were absent. So this is a direct womb test and the indirect womb test. For a direct womb test, I'm sure that the patient is having antibodies and the antigen both. For the indirect one, I'm sure the patient is having antibodies. Okay. And now I want to discover them. Is that okay?
Yes.
Okay. So that's about the autoimmune hemolytic anemia. Any doubt? Any doubt?
No, thank
No, thank you.
Okay. And remember, what cells this parvovirus B19 virus infects?
Erythroblasts.
You can be more specific.
Proerythroblasts.
These are pronormoblasts. Okay, we call them pronormoblasts. Stephen can give you this name, so make sure you remember it. The pronormoblast. Okay, the parvovirus B19 affects them. Okay, and they halt the RBC's synthesis. Okay, now comes the microangiopathic hemolytic anemias, in which you're having this hemolytic anemia in the small vessels. Okay. Okay, and yeah, what happens whenever you have a thrombosis in a vessel? Okay, whenever you have a thrombosis in a vessel and the RBCs will try to pass through these vessels, okay, they will get lysed, okay, within the vessels, and they will become the spherocytes or the helmet cells. Okay, and this is known as the microangiopathic hemolytic anemia. It is generally seen in the DIC or the TTP or the HUS, the SLE or the HELP. Okay, and you can also see them in the hypertensive crisis. Whenever a hypertensive emergency, you guys remember that in case of hypertensive emergency, you will be having which kind of this arteriosclerosis?
Hyperplastic.
Hyperplastic.
Yeah, hyperplastic type, right? In that case, you will be having a narrowing of the vessels, right? And because of narrowing of the vessels, right, you can have the lysis of the RBCs while they're trying to pass them, right? And what you can have is the intravascular hemolysis. Okay, so what you will see are the cystocytes on the peripheral blood smear, and this is known as a microangiopathic hemolytic anemia, right? It can affect the small vessels mainly, right? In case of macroangiopathic hemolytic anemia, this hemolysis will be occurring in the very large vessels like the aorta. Okay, so what happens? It generally happens because of the prosthetic valves. Whenever your body has a prosthetic valves, like in case of any kind of aortic stenosis case, and you have this valve replacement, right? In that case, you can have the RBC destruction. Also, in case of this aortic stenosis, also because you're having a very small size or a narrow passage for the RBCs from the aortic valve, these RBCs can get damaged, right? And what you will see is the cystocytes on the peripheral blood smear, and you call them the macroangiopathic hemolytic anemia. So please remember, the macroangiopathic hemolytic anemia is because of the mechanical destruction. Okay, very important. And the microangiopathic hemolytic anemias are because of the microthrombiles mainly. Okay, then you also can have the hemolysis because of the infections, and we have discussed that the malaria and the babesia. You guys remember the malaria and babesia, where these parasites will infect your RBCs and they will cause the lysis of your RBCs, right? So this is again a cause of destruction, the intravascular hemolysis. Is that okay?
Yeah.
So remember these causes. Any doubt on this page?
No, thank you.
Okay, now comes the leukopenias, the different causes of them. First is the neutropenia. Okay, please remember the chemotherapy. Whenever you give the patient chemotherapy, the patient will have the neutropenia mainly. Okay, you will call it an absolute neutrophil count whenever the neutrophil value will reach more less than 105,000. Sorry, 1,500. Okay, and you will call them a severe neutropenia whenever the value reaches less than 500, and at that time the severe infections can happen. Okay, the causes, other causes includes a sepsis. Okay, certain drugs like the chemotherapy we have discussed. In case of aplastic anemia, you will have the loss of lymphocytes, you will have the loss of neutrophils, macrophages, every other cell in the body. Okay, in case of SLE, in case of radiation, you can have the neutropenia. Okay, the treatment will be involving giving the patient GCSF, which is a granulocyte colony stimulating factors, right? Like the filgrastim. Okay. Second is the lymphopenia. Okay. Lymphopenia can happen because of the HIV. See, the HIV can only cause lymphopenia. It cannot cause a neutropenia. Okay. The corticosteroids, they can cause the lymphopenia, but they cannot cause a neutropenia. Okay. So please remember it. In case of HIV, you cannot have the invasive infections with the candida or with the aspergillus, right? Because in fact, because the invasive infections of this candida and the aspergillus can only happen because of neutropenia. So if you give the patient chemotherapy, then they can have these kind of infections, but in case of HIV, they cannot have this kind of infections, right? Remember that. Is that okay?
Okay.
Okay, so the HIV, SCID, you guys remember? You have this pancytopenia again in case of SCID. SLE, steroids, radiation, sepsis, and the post-operative causes. They can have the lymphopenia, right? And whenever you have a lymphopenia, you will have the superficial infections. Okay, you won't have the invasive infections of the fungi. You will have the superficial or the this mucosal tract infections of the fungi. Okay, like the this oral thrush or the intertrigo with the candida, right? Or the vulvovaginitis. Yes.
Yes.
So remember these ones. Now the causes of the eosinophilia. Okay, you will have the Cushing syndrome. Okay, you will have the corticosteroids. Both are because of high levels of cortisol or the glucocorticoids in the body. You can have a eosinophilia. Okay, because you know this cortisol or the glucocorticoids, they will sequester this eosinophils in the lymph nodes, and because of the sequestration, you will have a low value or low level of these eosinophils in the blood. Okay. Corticosteroids, they can cause a neutrophilia because they cause a demigration of the neutrophils from the vessels, from the blood vessels, right? So although you are having a neutrophilia, okay, your neutrophils cannot cross uh, the vessel wall, okay, and because of that, you will be having an increased risk of infections, right? The corticosteroids, they will decrease. Yeah, they will cause that. Okay, and they will cause the eosinopenia and the lymphopenia also. Eosinopenia because of sequestration of the eosinophils in the lymph nodes, and lymphopenia because of direct apoptosis of the lymphocytes. Okay, and same thing we have discussed. They will decrease the activation of the neutrophils and they will cause a demigration. So neutrophilia, but these are the dysfunctional type of neutrophils. Any doubt?
No, thank you.
Okay, now comes a neutrophil left shift. We have discussed that already previously. The leukemoid reaction, you can call it also, right? Whenever you have any acute infection, the immature neutrophils will be released in the blood circulation by the bone marrow. And as a result, you will see the more immature forms like the band cells or the one more time, metamyelocyte, right? So up to the metamyelocyte, you can have the this left shift, right, which is normal, okay? And you will have the neutrophilia, you will have the band cells, you will have the metamyelocytes on the PBS, right? And you call it the left shift, very important, okay? And you will call the leukoerythroblastic reaction whenever the left shift is seen with the immature RBCs, which is occur in the severe kind of anemias, okay? Or yeah, so a left shift is nothing but just a more immature cell which is present in your blood, right? And that would be it about. Any doubt on the neutrophil left shift? Yes.
I have a doubt.
Yes.
Is it similar to leukemioid reaction?
Yes. In case of leukemioid reaction, you can have the neutrophil left shift, right? A feature of leukemioid reaction it is.
But it has more premature cells.
No. Same cells. You can have the metamyelocyte in case of this leukemioid reactions, okay?
Yeah, okay.
And these more immature cells are because of this neutrophil left shift.
Right. Okay. Thank you.
Yes. You also need to know what happens to the bone marrow with the aging, okay? Please note that with the aging, your bone marrow will start replacing with the fat, okay? So you have an increased fat in the bone marrow and you have a decreased mass of the bone marrow, okay? Although it won't affect much, normally you have a normal blood levels, the RBCs will be normal, WBCs will be normal, okay? But in case of any acute blood loss, okay, these old age people will take time to recover from this loss of blood, okay? Because the bone marrow won't be responding properly, okay? So whenever the acute blood loss occurs, okay, and the body needs to rapidly regenerate the new cells, in that time their body cannot respond properly, okay? Very important to note that. So please note, with the aging you will have a high fat and a low mass, okay? In the normal conditions it won't cause any symptom, okay? The patient will be absolutely normal. But whenever an acute crisis happened and the bone marrow need to replace all these blood cells, then the symptoms will arise because the bone marrow cannot replace these cells very rapidly. It will take time for the bone marrow to do that, right?
Yeah.
This is about the aging process. Okay. Then comes the heme synthesis and the porphyrias. We have discussed the process already. First, you have the glycine and you have the succinyl coenzyme A. The glycine and the succinyl coenzyme A, they will be combined in the presence of vitamin B6 and with the action of enzyme aminolevulinic acid synthesis or the ALA synthetase. It is the slowest enzyme in this whole reactions, in this whole pathway. That means it is a rate limiting step, right? It will determine at what rate the synthesis can happen, right? So with the help of this ALA synthetase, you will have the synthesis of ALA. Now ALA will enter the cytoplasm, okay, and it will undergo a reaction which requires the enzyme ALA dehydratase to convert this ALA into the porphobilinogen, okay. Now this porphobilinogen with the help of enzyme porphobilinogen deaminase, okay, will be ultimately converted into the uroporphyrinogen 3. You can forget this substrate name, okay. Just remember that with the help of the enzyme porphobilinogen deaminase, you will be converting the porphobilinogen into the uroporphyrinogen 3, okay. Now with the help of enzyme uroporphyrinogen decarboxylase, you will be converting the uroporphyrinogen 3 into the corpoporphyrinogen 3, okay. Or you can skip this enzyme and you can directly say that the uroporphyrinogen 3 will be converting into the protoporphyrin ultimately with the help of the uroporphyrinogen decarboxylase, okay. Now this substrate will go to the mitochondria again, and within the mitochondria you have the this protoporphyrin will enter the mitochondria and it will convert into the heme after combining with the iron. Okay, and the chelating enzyme will work here, which is known as the ferrochelatase. It will cause the formation of heme ultimately, right? Is that okay? The whole reaction. You can forget about the corpoporphyrin 3 and the hydroxymethylbelane. Okay, Belen. Okay, just remember this ALA synthetase, which will form the ALA. Then the dehydratase will form the phosphorylation. Okay, and then the phosphorylation deaminase will form the uroporphyrin 3. Then the decarboxylase, which will form the protoporphyrin, or you can also remember this name if you want, right? So whenever you give the patient heme, okay, because ultimately all these reactions will gonna go from heme. If you already give the patient heme for the IV, with the IV route, let's say, then you can have the inhibition of this ALA synthetase. Okay, so increase in the heme will decrease the ALA synthetase, or a decrease in heme will increase the ALA synthetase, right? And the second thing, if you give the patient glucose, it is very also important. If you give the patient glucose, then it will inhibit this enzyme. So a treatment of all these disorders is to give the patient glucose. Is that okay?
Yes, yes.
Okay, so let's discuss all the diseases. We have discussed about the sideroblastic anemia already, in which you have a deficiency of ALA synthetase. Okay, we will discuss about this lead poisoning, in which you have a deficiency or the inhibition of the ALA dehydratase and the ferrochelatase. Because this ferrochelatase is inhibited, you will be having a high level of protoporphyrin in case of lead poisoning. Then you have the acute intermittent porphyria. As the name suggests, it will be episodic acute symptoms of the porphyria. Okay, it will be episodic, it will be acute symptoms of this disease. It is due to a deficiency of porphobilinogen deaminase, so that you will be having a high level of porphobilinogen and a low level of uroporphyrin 3. Along with that, you will be having a high level of aminolevulinic acid. And because the heme synthesis is now inhibited, that means the ALA activity will be increased. And as a result, you'll be having a more level of ALA, which is aminolevulinic acid. And this acid will be causing all the symptoms of the acute intermittent porphyria, right? Very important to note. And note one point also, right? That this enzyme, this ALA synthetase, it is also cytochrome P450 dependent enzyme. Okay, very important. So whenever you give certain drugs which will increase the activity of cytochrome P450, they will increase the activity of this enzyme also, and you can have a worsening of the symptoms of acute intermittent porphyria, right? Then you have a deficiency of this enzyme, which is uroporphyrin decarboxylase. Okay, that can cause the porphyria cutanea tarda. Okay, so that you will have a high level of uroporphyrin 3 and low level of protoporphyrin and the corpoporphyrin 3. Someone can ask you this, right? And as the name suggests, you will be having a cutanea tarda. That means it is a cutaneous reactions will be there. You will have a skin symptoms in this disease. Okay, so let's discuss every disease one by one. First is a lead poisoning. We have discussed that already, right? You will be having a microcytic type anemia. You will be having a ring sideroblasts, right? You will be having a basophilic stippling of the RBCs because of
RNA.
rRNA destruction, right? So this is all the features of the lead poisoning. In which person you should expect it? In the children, it would be due to a lead paint exposure, which could be due to any old house, right? For the adults, it could be a battery or the ammunition workers, right? The patient generally complains of the GI symptoms like the abdominal pain, nausea, vomiting. They will complain you with the psychiatric disorders. They can get the anxiety. They can cause the depression. They can cause, the loss of focus to the patient. They will tell you, okay, they will get a dementia also. Okay, increased forgetfulness will be there. The patient can also get the paralysis history. Okay, so these are all the symptoms of the lead poisoning. And when you do the PBS, you will find the basophilic stippling, right? And as well as the hypochondromic type of anemia. And when you give the patient, I would be about. And when you give the patient heme, okay, the symptoms will be resolved after giving the patient heme. Very important. So that's about the lead poisoning. Any doubt?
No, thank you.
Okay. Then comes the acute intermittent porphyria. Okay. It is an autosomal dominant mutation in the enzyme, which is porphobilinogen deaminase. As a result, you'll be having a high level of porphobilinogen and a low level of corpoporphyrin 3. The symptoms will be intermittent and acute on onset. Okay. The symptoms will be GI pain. Of course, you will get the nausea, vomiting, abdominal pain. You will get the peripheral neuropathy and the altered mental status. And generally, patient have a previous history of such type of episodes. So whenever you encounter a patient with recurrent abdominal pain, nausea, vomiting, as well as the psychiatric symptoms, and also the previous history of these symptoms, that means the patient is having a acute intermittent porphyria. Okay, you will also get the very red or the portwine color of urine. Okay, you will get the psychological disturbances, and whenever the patient consume alcohol or any other agent that can increase increase the activity of cytochrome P450, they will have the episodes of these symptoms. So patient can also tell you that they don't like alcohol because they will fail them, or they will make them very worse. Okay, this alcohol will make them very ill, so they just avoid the alcohol consumption. So patient can also have a history such like that. Okay, and yeah, the treatment includes patient giving the hematin, the hemin, okay, which is heme, so that the activity of this enzyme is decreased. Or you can also inject the glucose in the patient, and whenever after injecting glucose, symptoms will be resolved. That means the patient is having this enzyme deficiency. Is that okay?
Yes.
Then you have the porphyria cutanea tarda, okay, in which you're having a skin symptoms. You will have the blistering disorder in the skin. You have the blisters. You will have the skin ulcers. Okay, whenever you expose the skin to the sunlight, it is same as the xeroderma pigmentosum. Okay, in which you have these ulcers and these blisters whenever you expose the skin to the sunlight. Same thing in here. So you can just imagine a vampire in it, right? They cannot expose themselves to the sunlight. They only have this nocturnal type of thing. Okay, and symptoms again will be exacerbated whenever the patient try to consume the alcohol, of course, right? And please note that the porphyria cutanea tarda is associated with the hepatitis C. Step 1 will ask you this fact. It is associated with the hepatitis C. Treatment includes a phlebotomy, because you know that the heme synthesis not only happens in the bone marrow, but it also happens in the liver also, right? So in case of liver, you will be having a low level of this synthesis of the heme. Okay, so we'll have an increased hepatic dysfunction, right? So the treatment includes a phlebotomy, which will decrease the iron in the liver to kind of get rid of the symptoms. And one important drug that you can give patient is the hydroxychloroquine, which is an anti-malarial drug. Okay, it is kind of weird, but this anti-malarial drug is key to treatment for this porphyria cutanea tarda. Okay, and because of liver involvement, you can also have the high level of ALT and AST. Okay, on the biopsy, you will have the high level of iron. Is that okay?
Yes.
And if the step,
Flavor.
yeah,
Excuse. I have a question. The
yes,
phlebotomy does treat only the iron-induced liver damage, right?
yes, exactly.
Okay, thank you.
And if the step 1 asks you why you're having all these symptoms, so because of this uroporphyrinogen, which is a very photosensitive uh, porphyrin, right? This uroporphyrin 3, it is very much photosensitive porphyrin. That's why you're having a skin symptoms in this porphyria cutanea tarda. Okay, while this porphobilinogen, it is not very much photosensitive, and that's why you don't have any skin infections or any kind of skin symptoms in case of acute intermittent porphyria. Okay, any doubt on this page?
No, thank you.
So do remember these facts.
I have a question. Apart from
Yes.
these 3-4 types of significant diseases, do we need to remember the other types? Do we need to learn other types of porphyrias?
No, definitely not. Just these 3 types are enough for a step 1. Okay.
Okay, and we do not need to learn the other enzymes which are present in the pathway.
No, just 3 enzymes or 3-4 enzymes are enough. Okay, which is given the first state, the ferrochelatase, the decarboxylase, the deaminase, and the dehydratase and the synthetase enzyme. Okay, these 5 enzymes are enough.
Okay, thank you so much.
Okay, now comes the iron poisoning. Okay, and it could be of two types, either the acute poisoning or the chronic poisoning. Acute poisoning, whenever you have a sudden spike in the iron levels. Okay, and it generally because of some kind of a suicide attempt. Okay, or sometimes because of accidental ingestion by the children. Okay, because the iron tablets are kind of very much look like the candies. Okay, so they just ingest them in a very high amount and they will get this toxicity. Okay, sometimes it could be a suicidal attempt also, right? And the mechanism is because of, you guys already know, the free radical damage. Okay, and the peroxidation of the membrane lipids, right? Symptoms include the abdominal pain, vomiting, GI bleeding. Okay, you will get the GI bleeding, and because of that, you will get the coffee ground emesis. If you guys remember, the blood will mix with the vomiting and it will give the brownish appearance to the vomiting. So abdominal pain, a bloody vomiting, GI bleeding, which means bloody stools will be there, right? And you guys already know that this iron is a very important cause of the high anion gap metabolic acidosis. So what you will get is a high anion gap metabolic acidosis along with the hyperventilation. Multi-organ failure can occur and that can lead to the death of the patient. Okay. The treatment includes a Gashman patient, the chelation therapy, which means a deferoxamine. Okay. Or the gastric lavage could be done. Okay. If the iron is still not absorbed, then the gastric lavage is a very good solution for that. Okay. So yeah, that will be about the acute poisoning. Any doubt on that?
No, thank you.
So whenever you encounter a patient with a black watery stools, foul smelling, and a dark vomiting with abdominal pain along with hyperventilation and high anion gap metabolic acidosis, you will always think about the iron poisoning. Then comes a chronic type in which you have a slowly rising level of the iron. Okay, and we call that the you sometimes get this in the hemochromatosis. Okay, you will get it with the chronic blood transfusion reactions, with the chronic blood transfusions, like in case of sickle cell anemia or the beta thalassemia, right? So you will get symptoms just like the hemochromatosis, which includes a joint pain, and you remember the first and the second joint, which is
Metacarpophalangeal.
exactly. You will get the metacarpopharyngeal joint in that case, right? You will get the this gonadal atrophy. You will get the hyperpituitarism also. You will get a diabetes mellitus and the skin symptoms and all these things, right? Same as that of hemochromatosis. Treatment again includes a phlebotomy, right, and the chelation. In the phlebotomy, you will remove the RBCs and so does the iron. Okay. In case of chelation, you will chelate the iron, right? And please remember that the vitamin C, you cannot give it the vitamin C to such patients. Can anyone tell me why?
Fe3 plus to Fe2 plus conversion is done by
Yes. And this Fe2 plus is very much easily absorbed from the GIT, right? So it will worsen the symptoms. So you want to avoid giving the patient vitamin C. Very important to note. Any doubt in these two poisonings?
No, thank you.
Okay, now then comes the coagulation disorders. Okay, and yeah, for that we have discussed already the intrinsic pathway and the extrinsic pathway, right? We know that whenever you have any kind of damage to the intrinsic pathway, you will have a high PTT, and whenever any damage or any blockage happen to the extrinsic pathway, you can have a high PT, right? So whenever you have any damage to the common pathway, which means a factor 10, factor 2, factor 5, and factor 1. Okay, that means you can have a rise in both the PT as well as the PTT values. Okay, so PT basically tests the functions of the common pathway and the extrinsic pathway, which means a factor 1, 2, 5, 7, and 10. Okay, and in defect will cause a rise in the PT. Okay, you have the INR, which is the international normalizing ratio. Okay, in which you measure the patient PT level with the control PT. This is the normal PT levels, and this is a PT ratio of the patient. Okay, a ratio of 1 is absolutely normal. A greater than 1, which means the patient PT is very much increased or prolonged. So a more than 1 signifies a prolonged PT. Okay, and whenever you give the patient warfarin, when which you are inhibiting the factor 2, 7, 9, 10, you're actually you will measure the this INR of the patient. Very important. You will have a prolonged INR which is more than 1 in case of warfarin therapy. Then you have the PTT, okay, which will measure the common pathway as well as the intrinsic pathway, okay, except the factor 8 and the factor 13, because the factor 7 and the factor 13. Okay, this factor 7 is for the pathway of it is for the extrinsic pathway, not for the intrinsic pathway, right? So you won't get the increase in any you won't get any defect in the factor 7 pathway, right? Yeah, I don't wait. So whenever you have any coagulation disorder, okay, you need to make sure that whether it is due to a deficiency or whether it is due to any some kind of a autoimmune disease, some kind of a antibodies against the clotting factors, right? So for that, what you can do is you will replace the patient plasma with some normal plasma, right? And after replacing the patient's plasma with the normal plasma, if you get the normalization of the PT levels or the PTT levels, that means it is due to the deficiency. But even after mixing the patient plasma with the normal plasma, if you don't get to normal the PT and the PTT values, that means it is due to the antibodies, because the antibodies were still there, right? They will attack the new clotting factors and they will cause a prolonged PT and the PTT. Is that okay?
Yeah.
So you will do the mixing study in which you mix some normal plasma with the patient's plasma and you will see whether the PT is corrected or not. Then comes the disorders for the clotting factors. The one is the hemophilia, first one. Okay, you have three types, A, B, or C. In all of these types, you will be having a prolonged PTT and a normal PT, because it only affects the intrinsic pathway, not the extrinsic pathway. In case of hemophilia A, you will be having a deficiency of factor 8. In case of hemophilia B, you will be having a deficiency of factor 9. In case of hemophilia C, you will be having a deficiency of factor 11. Hemophilia A and B are X-linked and hemophilia C is kind of autosomal recessive. So you will find only hemophilia A and B in the males, not in the females, while the hemophilia C can be found both in males as well as the females. Okay. What will happen because of the clotting factor deficiency? You will be having a deep bleeding. You won't be having any stimulation or any stabilization of the platelet plug. So you will having a deep bleeding, right? You can have this easy bruising, of course. You will having a very bleeding after a very minor trauma. You will having a bleeding into the joints, which means the hemarthrosis, which is a very acutely painful condition. You will be having a very severe pain and a swelling of the joint, as you can see here, right? And when you do the fluid testing, you will find the RBCs in the fluid, right, in the synovial fluid. So that's how the patient is having a hemarthrosis, right? And the patient will also have a very deep bleeding or the tooth bleeding after the minor dental procedure, right? And multiple members of the patient family could be affected. Very important to note that too. Okay. But make sure whenever you have a patient who is female, okay, then she cannot have the hemophilia A or B. Very important. Treatment includes the giving patient desmopressin, which is an ADH analog that will give the patient von Willebrand factor, right? And this von Willebrand factor contains the factor 8, which is kind of a cure to the hemophilia. Okay, you can also give the patient factor 8 supplements or the factor 9 supplements or the factor 11 supplements for the hemophilia A, B, and C respectively. Okay, any doubt?
No, thank you.
Okay. Then comes the vitamin K deficiency, in which you're having a deficiency of protein factor 2, 7, 9, 10. Because a common pathway is also involved, so you can have elevated levels of PT as well as the PTT, along with the deep tissue bleeding, like the poor wound healing, or might be the this hemarthrosis, okay, or it could be the hemorrhage, the brain hemorrhage to the patient can happen. Okay, and yeah, so from here we can go to the neonatal vitamin K deficiency, okay, which is only seen in those neonates who do not have any post partum maintenance, okay, or the postpartum visits to the doctor, right? So they will have a very low vitamin K stores, okay, because you know that the gut bacteria are responsible for the vitamin K, and in a newborn you have an immature gut, okay, no bacteria were there initially, so that no vitamin K production happens. What what you will see is the intracranial bleeding. Because of that, the intracranial pressure will rise. You will have the altered mental status, okay, enlarging head circumference would be there. They will tell you the patient has a bulging fontanelles, Okay, which means they're telling you that the height size is increasing. Okay, and the patient will also have the inside eye, which is a down-driven eyes. As you can see here, you have the down-driven eyes. Okay, and the patient will be unable to trace them upward if you ask them to do so. GI bleeding, cutaneous bleeding can also happen. Joint bleeding can also happen in case of vitamin K deficiency. And you will suspect the vitamin K deficiency in adults in case of any antibiotic therapy or the warfarin therapy. Is that okay?
Yeah.
So that's all about the hemophilia and the vitamin K deficiency. Any doubt?
No, thank you.
So we're done with the clotting factor disorders. Now comes the platelet disorders. Okay. And whenever you have any platelet defect, you will have an increase in the bleeding time. In case of any clotting factor defect, you will be having a normal bleeding time. Okay, but an increase in the PT and PTT. In case of platelet defect, you'll be having an increased bleeding time, but a normal PT and PTT. Very important to note. And you will have a more superficial bleedings like the skin bleeding or the mucosal bleedings. Okay, no organ bleeding is seen, no joint bleeding is seen. Okay, and you will have the micro hemorrhages also. Okay, which is seen as a petechial rash in the skin. Okay, and the epistaxis. Okay, so first we have the Bernard-Solé syndrome. We have discussed that already, in which you have a mutation of the glycoprotein 1b receptors for the von Willebrand factor. Okay, what you will have is the abnormal resuscitation test. Even after giving the patient this drug, the clumping of the platelets won't increase, which means the platelets are lacking the glycoprotein 1b receptors. Okay, apart from that, you will also see the large platelets. This is very important thing. Okay, the presence of these large platelets will help you differentiating it with the von Willebrand factor disease. Okay, very important to note. And the blood smear will show no clumping, right? And what you will have is an increase in the bleeding time. Okay, and wait about. And the platelet count will be absolutely normal, or it could be sometimes slightly decreased. Any doubt on that?
No, thank you.
Any doubt? Yeah. Okay, now comes the Glanzmann thrombosthenia. Okay, in which you're having a deficiency of glycoprotein 2b3 receptors. As a result, the clumping again won't occur. But if you give the patient, oh, that would this is all. Okay, so the patient will be having a deficiency of glycoprotein 2b3, which means there is no platelet to platelet aggregation happens. Okay, if you give the patient testosterone, then the clumping will be very much increased because of activation of this glycoprotein 1b receptors, which makes sure that the patient is not having any Bernard-Solé syndrome. Okay. Yeah, you will have a high bleeding count. You will have a high bleeding time and a normal platelet count, of course, right? So that would be it about the Glanzmann thrombosthenia. Then you have a immune thrombocytopenia, okay, in which you're having antibodies against the platelets. It is generally seen after some kind of an infection, for say a viral infection. Okay, so whenever you want to diagnose a patient with the immune thrombocytopenia, you need to have any patient history of recent infection or any other autoimmune conditions. Okay, you will be having a formation of antibodies against the glycoprotein 2b3a receptors. Okay, so ultimately the splenic macrophages will phagocytose the platelets. Okay, it is mostly idiopathic and sometimes could be associated with the autoimmune diseases like the SLE we have discussed. Okay, like the viral illnesses and the malignancies. Okay, this is how you get the immune thrombocytopenia. You will have a low platelet counts because these antibodies will keep on destroying the platelets, and you will have the high bleeding time also, right? And yeah, for the treatment, you can remove the spleen because ultimately within the spleen, you will be having the destruction of all these platelets. So our treatment includes the splenectomy. Very important to note. Any doubt on the thrombocytopenia, immune thrombocytopenia?
Can you explain the ristocetin study that we did
Yeah, we will.
in
Yeah, we will go to that. But before that, any doubt on this part? Thrombocytopenia.
no. Thank you.
Okay, so see, for the resuscitation studies, what you will do, you will give the patient this drug, and you know that this drug will activate the glycoprotein 1B receptors and the von Willebrand factor. So whenever you give the patient this drug, okay, these receptors and the substrates will get activated, and what you will get is the more clumping. Okay, but in the scenarios in which you're having a deficiency of either a substrate or the receptors, right? In that case, if you give the patient this drug, then the clumping won't occur, then the aggregation won't increase, and that's how you know that the patient is having a deficiency. Okay.
Yeah,
Yes.
got the point. Yeah, got it.
Okay,
Thank you.
so you give the patient this drug, and if the clumping increased, it is normal. If the clumping is not increased, then they are abnormal. That's about it. Okay, now comes the uremia, okay, which is seen in the renal failure. Because of the accumulation of toxins in your body from the uremia, they will interfere with the platelets function, and as a result, the platelet dysfunction will occur. What you will get is the increase in bleeding time, but a normal platelet count. Okay, what you will see is again the superficial bleedings, like the nose bleeding, or the petechial rash, and any other symptoms would be there, right? But just know that the platelet count will be absolutely normal. Okay, it's just the patient is having a loss of platelet function, and it is because of the toxin accumulation in the body seen in the chronic kidney disease. Okay.
Yeah.
Okay, then comes the thrombotic microangiopathies. Okay, the causes we have discussed: the thrombotic thrombocytic purpura (TTP) or the HUS, which is hemolytic uremic syndrome. Okay, in both these disorders, because they are not the clotting disorders, so the PT and PTT levels will be normal. But because of the formation of this microthrombi, all of the platelets will be consumed, and what you will get is an increase in the bleeding time. So an increase in the bleeding time and a normal PT and the PTT will be seen, right? Okay, so first of all, it is the thrombotic thrombocytic purpura, in which you have a deficiency of the ADAMTS13, okay, which is a enzyme or a metal proteinases which destroy the von Willebrand factor. Now, because of the mutation of this enzyme, the von Willebrand factor will keep on accumulating in your body, and it will activate the platelets for the clumping, and as a result, the thrombi of the platelets will be formed, right? Because you know that the factor 8 and von Willebrand factor will combine to form the wheat platelet plug, right? So in case of high levels of this von Willebrand factor, you will be having a microangiopathy formation, the microthrombi formation, right?
Yes.
Okay, so you will have a decrease in the degradation, you will have an increase in the multimers. Okay, the platelet to platelet aggregation or the addition is also very much increased because of presence of high von Willebrand factors. Okay, treatment, it includes a plasmapheresis in which you remove the antibodies. You can also give the patient rituximab, which is an anti-CD20 inhibitor. Okay, and wait, now I doubt.
No, thank
Then
you.
comes then comes the hemolytic uremic syndrome. Okay, which is mostly seen in the children. Okay, it is because of the Sija-like toxin, which is seen in the enterohemorrhagic E. coli. Okay, serotype 0157H7. Okay, first of all, you will have the episodes of bloody diarrhea, and then you will have the thrombotic microangiopathy in these kind of patients. Okay, so what are the presentation of these disease? First of all, you will get a triad of the thrombocytopenia with which means the low platelets. You will get a microangiopathic hemolytic anemia, in which you will have the cystocytes, okay, low hemoglobin and high LDH count, and above that you will also have the acute kidney injury also because of the microthrombies in the renal vessels. You can also have the kidney injury. So a kidney injury, okay, and the microangiopathic hemolytic anemia, which means the low hemoglobin cystocytes, and the thrombocytopenia, which means low platelets. These are the classical triads common for both the thrombotic thrombocytic purpura and the hemolytic uremic syndrome. Okay. And other thing, for the thrombotic thrombocytic purpura, you will also have the fever. Okay, you will also have the neurological symptoms, which could be any psychiatric symptom. Okay, like the dementia could be there. Okay, sometimes a stroke can also happen, which will make the patient paralyzed. Right. In case of hemolytic uremic syndrome, the extra symptoms includes the bloody diarrhea. Okay, so a patient with a thrombocytopenia, bleeding complications after the diarrhea, which means the hemolytic uremic syndrome. A patient having this all this the thrombocytopenia, okay, and the hemolytic anemia, the kidney injury, along with the fever and the psychiatric symptoms. That means we are talking about the thrombotic thrombocytic purpura. Is that okay?
Yeah.
The treatment includes again the steroids, rituximab, plasmapheresis. In case of hemolytic uremic syndrome, you can give the patient supportive care only. That would be all about the TTP and HOS. Is that okay?
Yeah.
Okay. Okay, so we will take a short break of 10 to 15 minutes again, and then we will meet back. Okay.
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 A purely the clotting disorders in which you have generally only increase in the PT and PTT, no increase in the bleeding time. Okay. And now we are going to discuss these disorders in which you have an increase in the the disorders which affects the bleeding time as well as the PT and the PTT also, right? So first one is the von Willebrand disease. Now, because you guys know that a von Willebrand factor is responsible for the clumping of the platelets, right, with the endothelium, for the attachment of the endothelium. For the attachment of the platelets with the endothelium, as well as this factors also carries the factor 8, right? So whenever you have a deficiency of this von Willebrand factor, okay, you will have first is the increase in the bleeding time, because the aggregation of the RBCs cannot, because of the aggregation of the platelets cannot happen with the endothelium, right? And second is the increase in PTT because of loss of factor 8. Is that okay?
Yeah.
Okay. So in this order, disease, you will have the increase in the bleeding time as well as increase in the PTT. Okay, it is an intrinsic pathway causing the coagulation disorder. Okay, and why? Because of one Willebrand factor, it carries the factor 8 also. So you will be having a defective platelet plug formation, right? It is an autosomal dominant condition. No platelet to platelet aggregation will be seen even after mixing the blood with the aristostatin. You will inject the aristostatin dye and you will check for the aggregation. Okay, aggregation won't happen. But see that the platelets are absolutely normal. The shape of the platelets or the size of the platelets is absolutely normal. Okay, but the size and the shape of the platelets are changed in case of Bernard-Soulier syndrome, right? Apart from that, if you mix the patient's blood with the normal plasma, then you can have the normalization of all the symptoms. But in case of Bernard-Soulier syndrome, it won't provide any symptomatic relief. Why? Because it just the platelets are defective, not the protein is deficient, right? So you can do the mixing studies, you can do the ristostatin test, okay, and plus you will have the superficial bleeding as well as the deep bleeding in case of von Willebrand disease. Okay, you will have the petechial rash, you will have the superficial bleeding like the epistaxis, as well as you will have the deep tissue bleedings like the prolonged menstrual flow, okay, or maybe the bleeding after a minor trauma. Okay, it would be seen only in case of von Willebrand disease and the hemophilia, right? Whenever you have a clotting disorders, but it won't be seen in case of platelet disorders. Only you will see the superficial bleeding in case of platelet disorders, right? So a patient with a deep tissue bleeding history, okay, along with that loss of platelet aggregation and an increase in the bleeding time, which means the patient is having a von Willebrand disease. Okay, so you have to differentiate between the hemophilia, the von Willebrand disease, and the Bernard-Soulier syndrome, because all of these three diseases are kind of very much linked up with each other, right? So if you're having only a deep tissue bleeding, okay, and the patient is a male, then only you think about the hemophilia. If the patient is female, then you cannot think about the hemophilia first thing. If you have a superficial as well as a deep bleeding, okay, along with the abnormal platelet aggregation, which means we are talking about the von Willebrand disease. If you are having just a superficial bleeding, okay, and along with that the abnormal type of platelets, okay, and a negative mixing studies, which means no improvement of the symptoms even after mixing the plasma, that means we are talking about the Bernard-Solier syndrome, not the von Willebrand factor disease. Is that okay?
Yeah.
So this is a von Willebrand factor disease. Then comes a DIC, disseminated intravascular coagulation, in which you have the consumption of all of the clotting factors because of this formation of microthrombi. So you will be having a consumption of the platelet, so that you will have a low platelet count. Okay, you will have the high bleeding time because of that. Because of the consumption of the clotting factors, you will be having a high PT as well as the PTT. Okay, because of the widespread clotting factor activation, you will have the deficiency of these clotting factors. Okay, and the causes includes a snake bite, sepsis. Okay, trauma can do that. Any obstetric complication whenever you have this amniotic fluid embolism. Okay, after the delivery of the baby. Okay, the mother can have this amniotic fluid embolism. Okay, and after the amniotic fluid embolism, the patient can also have the DIC. Okay, or let's say the abrupto placenta. If you guys remember the case, in case of abrupto placenta, you will be having the activation of the thromboplastin or the tissue factor, right? And because of this activation of tissue factor, you will be having a widespread coagulation in the blood that can lead to the DIC. Okay, so the obstetric complications like the amniotic fluid embolism or the case of this abrupto placenta, you can have the DIC. Other causes include the pancreatitis, malignancy, nephrotic syndrome can also do that. Transfusion reactions can also do that sometimes. Okay, so what you will have because of the formation of microthrombi, okay, you will have the respiratory distress, very important. You will have the renal output decrease. Okay, you will have the bleeding from the venous sites. Okay, from the IV catheter sites. Like if you have any IV sites, okay, then the bleeding will start there. The mucosal bleeding can also happen, right? The oligouria can happen, respiratory distress can happen, ecchymosis can happen, and the petechia can happen. These are all the symptoms of DIC. So whenever you have a patient who is in the hospital and having some IV sites, and suddenly the patient start bleeding from the IV sites, you will think about the DIC in that. Okay, and yeah, that's about it. And so what are the lab tests you will see? First of all, you will have the high PT, high PTT. You will have the low platelet count. You will have the high bleeding time. Apart from that, because proper the coagulation is happening. Okay, so after the formation of fibrin and the meshwork of the fibrin, the degradation of the fibrin will occur. That means the plasmin pathway will be activated or the fibrinolysin pathway will be activated. So we'll have a high D dimer level. Okay, you will also have this low factor 5 and the factor 8. Okay, so I increased in the D dimer levels, or I can say the fibrinolysin. Okay, a decrease in the fibrinogen level and a decrease in the factor 5 and factor 8 level, decrease in the protein C and protein S also. This all signifies the DIC. Is that okay?
Yeah.
So do remember these facts about the DIC. You will have a widespread coagulation throughout the body, which means the consumption of all the clotting factors. High PT, high PTT, high bleeding time, and low platelet count. High for degradation of these fibrin co-products. That means a high D dimer level, okay, and low level of all the proteins which are involved in the coagulation, right? So that's about this DIC. Then comes the hereditary diseases in which you're having a hypercoagulability, right? Okay, in the previous diseases, we have discussed all the scenarios in which you're having a loss of coagulation, right? In this disorder, we're not going to discuss about the hypercoagulable states. Okay, the first one is the antithrombin deficiency. You guys remember the antithrombin 3, which is responsible for the inactivation of factor 2, factor 10, factor 7, or pretty much any factor, right? So if you're having a deficiency of this antithrombin 3, then you have a decrease inhibition of the factor 2 and the factor 10 mainly, right? And as a result, you will be having a hypercoagulable state. Now, it won't affect much the patient. The patient will be asymptomatic even though, right? But, if you give the patient heparin, because you guys know that the heparin function through the antithrombin 3, right? If you give the patient heparin, then it won't increase the PT or the PTT in the patient, right? And that's how we know that the patient is having a antithrombin 3 deficiency. Is that okay?
Yeah, yeah.
Do remember, whenever you give the patient heparin, if the PTT is not increased, that means the patient is having an antithrombin 3 deficiency. Second comes a factor 5 laden, which is an autosomal dominant mutation, okay, in which your factor 5 will become resistant to the degradation. So again, you will be having a hypercoagulable state. You will be having a recurrent episodes of deep vein thrombosis. Okay, the patient will be having a recurrent episodes of cerebral vein thrombosis. Okay, and plus the recurrent pregnancy loss. Very important. The recurrent pregnancy loss will be there. And whenever you encounter a case of a recurrent pregnancy loss, first of all, you will think about the trisomies and the translocation defects. Remember from the biochem lectures, we have discussed how the translocation defects are the most common cause of this recurrent pregnancy losses.
Yeah, yeah.
So first of all, you will think about this translocation defects. Second, you can think about the SLE, right? Or along with the SLE, one more disease, which is
Antiphospholipid antibody syndrome.
exactly antiphospholipid antibody syndrome. Okay, and apart from these disorders, you will always think about the factor 5 laden. Okay, so 3-4 names. First is the translocation defect. Second is the SLE. Third is the antiphospholipid antibody syndrome, and fourth is the factor 5 label. Whenever you encounter a patient with the recurrent pregnancy losses, and one more, the anatomical defect in which you have an abnormal uterus. Does anyone remember?
Biconvert uterus.
Exactly. Okay, in that case also you can have a recurrent pregnancy losses. So whenever you encounter a case of a patient with recurrent pregnancy losses, think about these 4-5 causes. Okay, so yeah, you will have the venous thrombus. Please remember, you will have a venous thrombus, not the arterial thrombus. Okay, so deep vein thrombosis or the cerebral vein thrombosis will be there, not the artery thrombosis. Then comes a deficiency of protein C or the protein S. Okay, it is again, the condition will be asymptomatic. It won't cause much symptoms, but because you guys know that if I give the patient warfarin, then shortly after the factor 7 is inhibited, the protein C and protein S will be inhibited, right? Because they have the second smallest short half-life, right? So
Yeah.
if I give the patient warfarin, they're already the deficiency of this protein C and protein S, and above that, if I give the patient warfarin, then what's going to happen? A super deficiency of these proteins, and as a result, I will get the hypercoagulable state. Okay, the patient will have a skin necrosis. Very important. The patient will have a skin necrosis with hemorrhage if I give the patient warfarin. So please remember, if you encounter a case of a patient who is receiving the warfarin and shortly after she or he received the warfarin, she developed the necrosis in the skin. Okay, any skin reaction from the agent. That means she's having a deficiency of protein C or protein S. Is that okay?
Could you please explain once again the protein C and S deficiency, the features, why we get them?
See, you know about the short half-life
Yeah, yeah.
of the factor 7, and after factor 7, the shortest half-life is of the protein C and protein S.
Yes.
If you give the patient warfarin, then it will first inhibit the factor 7 because of its shorter half-life. Then it will inhibit the protein C first before any other clotting factor, right?
Yeah.
So you will be having a transient hypercoagulable state because of that.
Yeah.
In normal patients, it won't do much, but in case of a patient who is having already a deficiency of protein C and S, if you give the patient warfarin above that, then they will have a extreme deficiency of these proteins, right?
Yeah, yeah.
And a very high supercoagulable state, right?
Okay, yeah, yeah, I got it now.
They will have a coagulation, they will have a venous thrombosis, and they will have a ischemia and necrosis, especially of the skin.
Okay, yeah, got it. Thank you.
And now the prothrombin gene mutation, in which you have a increased production of the prothrombin. Okay, again, you will have a hypercoagulable states. You will have a deep vein thrombosis, cerebral vein thrombosis, and other things. So it is a prothrombin gene mutation. Okay, other causes of the hypercoagulability, it includes the antiphospholipid antibody syndrome. Okay, you guys know, in case of antiphospholipid antibody syndrome, I'm having a this hypercoagulability, right? And So in that case, you will again have the venous thromboembolism. You can even have an arterial thromboembolism in case of antiphospholipid antibody syndrome. And apart from that, you will also have a recurrent pregnancy losses. Okay. In case of vitamin B12 or the folate deficiency, you guys know that the patients will be having a homocystinuria also, right?
Yes.
So these patients can also have a hypercoagulable state. Is that okay?
Yeah.
So other than these hereditary conditions, other causes of the hypercoagulability state includes the antiphospholipid antibody syndrome and the vitamin B9 or vitamin B12 deficiency. Any doubts so far?
I have one question.
Yes.
Is APLA syndrome, this antiphospholipid antibody syndrome, a part of SLE?
Yeah, you can say that. Some patients with the SL they also have this syndrome, but this syndrome can exist independently also. Okay.
Okay. Yeah.
So
Okay, got it.
sometimes a part of SL is sometimes independent.
Okay, got it. Thank you.
Okay. Now comes the blood transfusion therapies. Mostly whenever you encounter a patient with the anemia. Yes. Okay. Mostly whenever you encounter a patients with the anemia, right? You always want to give them the packed RBCs without any plasma, because you know that the plasma contains the antibodies and other proteins also that can cause certain blood transfusion reactions. All right. For example, the IgA antibodies. Okay, so you will so in the patients who are who is having a deficiency of the selective IgA antibody, right? So they can cause, so they can get what kind of reaction? A patient with selective IgA, not type 2 or type 1 hypersensitivity. Okay.
How?
Type 1.
How? You explain how?
Because in patients who are deficient of this IgA antibody will be foreign to them, right?
Yeah.
So whenever I put any blood product in these patients that contain the IgA antibodies, okay, my IgE antibodies will get activated against them, and they will cause this type 1 hypersensitivity. All right.
But why IgE would be stimulated?
Because these are like it is like an allergen to the body. Just like any food allergy or any kind of toxin allergy, this is same type, that type of thing. Okay, because of the IgA deficiency, because IgA is not in my body, so whenever I get IgA from anywhere else, it is a foreign product. Okay, and my body will respond to it by the hypersensitivity reaction, by the type 1 hypersensitivity mainly. Okay.
Okay. Thank you.
So in order to prevent such type of conditions, okay, because the plasma also has some minor antibodies which can act against my foreign which can act against my own body these antigens, right? So in order to prevent these conditions, I always give the patient packed RBCs, not the complete blood. Okay, very important to know. If I have the platelet lots, then I will replace the platelets. Okay, as you can see here. If I have a warfarin kind of toxicity, then I will always give the patient fresh frozen plasma or the prothrombin complex concentrate. Okay, either the fresh frozen plasma or the PCC. Okay, but because it contains the factors 2, 7, 9, 10, and protein CS. Okay, so all the factors which are being inhibited by the warfarin, this PCC or the fresh frozen plasma contains all these clotting factors. So I use them for the warfarin toxicity. Okay, or any kind of cirrhosis, because you know that these clotting factors are synthesized by the liver. So in patients with the cirrhosis, I can give the patient PCC. Okay, and whenever I need the immediate anticoagulation reversal, I will give these agents also. Then you have the cryoprecipitate, okay, which contains a factor 8 and factor 13. Okay, factor 1 will be factor and the fibronectin. Okay, so mainly the common pathway factors it contains. Okay, so whenever I have the hemophilia, I will try to give the patient cryoprecipitate for the hemophilia because it contains the factor 8. Very important. And it is not helpful in the warfarin toxicity. Okay, again, very important. And whenever you give the patient blood products, okay, blood transfusions, Okay, so in case of packed RBCs, okay, these cells. Just give me a second. You always mix these bloods with the citrate. Okay, and citrate is a calcium chelator. Now, why would you mix my blood with the citrate?
To
As an
anticoagulant.
anticoagulant.
Yeah, because citrate is an anticoagulant, right? So every blood product, it contains the citrate in it, and citrate is a chelator of the calcium. Okay, if I give a normal or a very little blood transfusion to the patient, then it won't cause any kind of symptoms, right? But a patient with a severe blood loss, okay, and I transfuse, very large blood products, okay, like 5-6 units of blood maybe. In that case, the citrate will chelate the calcium. It can cause the hypocalcemia. Okay, so please remember, the blood transfusions are an important cause of the acute hypocalcemia. The patient will acutely got the symptoms of these spasms, okay, and these the paresthesias, okay, and other symptoms also. Okay, so do remember this thing about the blood products. Okay, and the RBCs, they might get rupture, okay, and they can release their potassium. So with the large blood transfusions, I can also get the hyperkalemia. Okay, remember these two facts. The acute hypocalcemia, which is because of the large unit of blood transfusions, and similarly I can get the hyperkalemia also. Is that okay?
Yeah.
Okay, so we have finished with the RBCs completely and the platelets completely. Okay, and now we will study the WBCs, the disorders that involves the WBCs. Okay, so leukemia is a tumor of blood cells, of course, and lymphoma is a tumor of lymph nodes. Okay, very important. And the tumor cells in the leukemia, they're mainly found in the peripheral bloods, and the tumor cells in the lymphoma, okay, they're mainly present in the lymph nodes. And because you guys know that the lymph nodes, they have these cells, the lymphocyte, which are rapidly dividing already because of an infection. So how will you differentiate a lymphoma with a normal reactive lymphadenopathy, let's say? You can say the reactive lymphoid hyperplasia. How you can differentiate between the lymphoma and the reactive lymphoid hyperplasia?
Clonality of the cells.
Exactly,
Like
the
they are
clonality of that.
polyclonal.
Exactly. Whenever you have an infection, you will have a polyclonal type of the cell proliferation, right? Multiple type of cells will be proliferate. But in case of a malignant transformation, only one lineage of cell or a one type of cell will be proliferating. Okay, so whenever you have a monoclonal proliferation, that means a cancer. Whenever you have a polyclonal proliferation, that means it is a uh, uh, normal reaction. Is that okay?
Yes.
Otherwise, lymphadenopathy will be present in both. Mitotic figures will be seen in both, right? So this is not the hallmark feature of any cancer. Okay, very important to note that. So let's discuss the Hodgkin's versus the non-Hodgkin's lymphoma. Okay, both these tumors, they involves the constitutional symptoms like the fever, fatigue, weight loss, which is seen with any kind of tumor, of course. Okay, but the Hodgkin's lymphoma is kind of a localized type of tumor. Okay, it involves only one group of lymph nodes. Okay, for say the lymph nodes of the leg, of the neck, okay, or the axillary lymph nodes, okay, or the cervical ones, right, or maybe the inguinal lymph nodes. So only one group of lymph nodes are involved in case of Hodgkin's lymphoma. Okay, and the extranodal involvement is not there, which means the involvement of liver or the involvement of spleen is also absent in case of Hodgkin's lymphoma. So whenever you have a lymphoma which only involves a group of lymph nodes, no other organs, okay, no other lymph nodes, that means it is a Hodgkin's lymphoma. Okay, and because very few lymph nodes are involved, that means it has a very better prognosis. Okay, the characteristic feature of the Hodgkin's lymphoma is the Reed-Sternberg cells, which is this type of cells you can see. This cell has two nucleuses, and these are all the lymphoma cells. These are all the lymphocytes, as you can see, very dark blue cells. And in between these dark blue cells, you have this multinucleate cell, which has two nucleuses. This is the Reed-Sternberg cell, a very hallmark feature of the Hodgkin's lymphoma. It is most commonly seen in the patients who are old age or who are very young. Okay, so a bimodal type of distribution is seen. Either the patient will be very young or a patient will be more than 55 years of age. Okay. And it is also associated with the Epstein-Barr virus, and you can call it a AIDS defining illness also, because mostly the patients who are immunocompromised, you can see the Hodgkin's lymphoma in them. Okay. And the Epstein-Barr virus is a very important cause of the Hodgkin's lymphoma. Very important. Okay. And the Hodgkin's lymphoma shows the osteoblastic type of metastasis. So whenever you have a bone pain in case of Hodgkin's lymphoma, what you can have is a formation of bone, not a destruction of bone. Is that okay?
Yeah.
Then comes a non-Hodgkin's lymphoma, which includes some multiple lymph nodes. First of all, it is not a group of lymph nodes, but throughout the body, any lymph nodes could be affected. Okay, or multiple areas are also affected. Apart from lymph nodes, the spleen and liver, which means extranodal tissues, are also involved. So you will get the hepatosplenomegaly in case of non-Hodgkin's lymphoma. Okay, it could be of B type, it could be of T type, depends. Okay, and it has of many types. We will discuss in the next pages also. Okay, don't worry about that. And these are associated with the HIV, Epstein-Barr virus, or the STLV. These three viruses are very much involved in case of non-Hodgkin's lymphoma. Okay, so whenever you encounter a patient who is having a lymphadenopathy in multiple areas of the body, like the inguinal lymph nodes or the axillary lymph nodes and the cervical at the same time, along with that, the patient is having a hepatosplenomegaly with the systemic symptoms like the fever, fatigue, and weight loss, that means you are dealing with the non-Hodgkin's lymphoma. Is that okay? Yeah.
Yes.
Okay, then let's discuss something more about the Hodgkin's lymphoma. Of course, we have discussed the hallmark feature is the Reed-Steinberg cells, right? And other thing, other than the Reed-Steinberg cells, because they are positive for the CD15 and CD30. So whenever you want to diagnose a case of Hodgkin's lymphoma, okay, what CD markers you could use? You could use the CD15 and CD30. Okay, and on the biopsy, you will see these type of cells, the Reed-Steinberg cells. Okay, these are the hallmark features of the Hodgkin's lymphoma. Remember that. It has four types: the nodular type, the lymphocytic raised, the mixed cellularity, and the lymphocyte depleted. Okay, you don't need to remember every subtype of that. Just know that in case of Hodgkin's lymphoma, you can have the eosinophilia also. Step one can ask you this case. In case of non-Hodgkin's, in case of Hodgkin's lymphoma, you can have the eosinophilia. It is a very important thing. And the basophilia is seen in
CML.
CML, exactly. Okay, don't confuse. Eosinophilia for the Hodgkin's and basophilia for the CLL. Any doubt on this page?
No, thank you.
Okay, now let's discuss the subtypes of the non-Hodgkin's lymphoma. The first one is the Burkitt's lymphoma. Yes, it also has a seed because it is a lymphoma. It is a lymph node tumor. Sorry, it involves the lymphocytes, right? So you always have the positive markers for the lymphocytes also, the B lymphocytes mainly. And apart from the B lymphocytes, you also have the CD15 and CD30 as positive. Is that okay? Okay. Now let's talk about the Burkitt's lymphoma, in which you have a the translocation of the 8 and 14. Okay. This chromosome number 8, it contains the c-MYC gene, and the chromosome number 14, it contains the Ig heavy chain. And by default in our body, the Ig heavy chain is synthesizing in a very high amount, because we need the antibodies continuously, right? So this IV heavy chain is continuously synthesizing in our body at a very high amount. Now, if this gene reach to this this Ig heavy chain location, okay, then because of by this default process, the c-MYC production will be increased also, right?
Yeah.
And that's why you get the very high production of c-MYC in case of this translocation. And whenever you have a high c-MYC, what's going to happen? You will have the Burkitt's lymphoma, because it is a proto-onco gene, right? What you will see on the first of all, the symptoms, again you will get the symptoms like the fever, fatigue, weight loss. Multiple lymphadenopathies will be there. Hepatosplenomegaly could be there. When you do the biopsy of the lymph nodes, what you will see is the starry sky appearance. It is nothing but yeah. See, you're having lots and lots of lymphocytes here. As you can see, these are all the bluish shells you are seeing. These are all the lymphocytes. And because many lymphocytes are proliferating here, so the hypoxia will ultimately occur. And some of the areas the lymphocytes will die. And in that areas, the macrophages, they will digest these cells and they will form the apoptotic bodies here. So all these the lightish areas that you are seeing here, they all contain the macrophages. Okay, and macrophages here are digesting the lymphocytes, the died lymphocytes or the damaged lymphocytes. Is that okay? And this is a starry sky shape pattern, starry sky appearance. Okay.
Yeah.
What is fungible macrophages?
Yeah, these are some modified macrophages. You see, they have a special type of cytoplasm. Okay, and this macrophage is kind of filled with this debris of the cells, right? So these are kind of modified type, and you call them the tingible body macrophage. It's just a fancy name for the macrophage, nothing much. It's just a macrophage which is filled with lots of this debris. Okay, and yeah, that's it.
Okay.
Okay.
Thank you.
And apart from that, the lymphoma cells, the lymphocytes in case of Burkitt's lymphoma, these are kind of like this. They have this large cells and a very large cytoplasm. You have these large cells with a large cytoplasm. Okay, and you have these vacuoles also. Okay, so step one, they won't sometimes give you this starry sky shape pattern, but what they will do, they will further zoom in this figure. Okay, and they will show you the individual cell. They will show you. Okay, and what you will see on the lymphoma cells, these are some large cells with a large cytoplasm and with a large nucleus and a vacuolated cytoplasm. Okay, this is how this lymphoma cell look in Burkitt's lymphoma. Is that okay?
Yes.
Now, most of the endemic cases are associated with the Epstein-Barr virus. Okay, and yeah, for the sporadic form also exists without Epstein-Barr virus. Okay, and the sporadic forms can also happen in the abdomen. Okay, so you might sometimes confuse it with the mild lymphoma in case of the H. pylori because it happens in the abdomen, right?
Yeah.
Do not get confused because in case of H. pylori infection, you will be having a chronic history of the gastritis, of the abdominal pain, or this nausea, vomiting, and the burning sensations, right? But in case of this Burkitt's lymphoma, you will be having a multiple lymphadenopathy in the GI system, but no previous history of any gastritis. Okay, so a history of gastritis is very important in able to differentiate between these two conditions. Okay.
Yes.
Then comes a diffuse large B-cell lymphoma. It is the most common type. Okay, and it is associated with the mutations in the BCL2 and BCL6. Remember, these are the anti-apoptotic genes and proteins, right? So the cells will become a kind of very much resistant to the apoptosis, and that's why they can cause the lymphoma. Okay, they're generally seen in the HIVs. Okay, and it's a most common type. Nothing much to know about these lymphomas. Third one are the follicular lymphoma. Okay, and in case of follicular lymphoma, you will be having a translocation of the 14 and 18 chromosome. On the 14, you will be having a Ig heavy chain. Okay, Ig heavy chain formation, and on the 18, you will be having a BCL2. Now, if the BCL2 reaches at the location of this Ig heavy chain, then by default, the production of BCL2 will be increased. And as a result, you will get the resistance of the apoptosis in these cells. Okay. So what you will see on the biopsy, you will see the multiple the follicles in the lymph nodes. Okay. Whenever the step one give you a histology of the lymph nodes and you are seeing multiple follicles in it, that means they are giving you a case of follicular lymphoma. Okay, you will see the multiple follicles. And the special type of lymphadenopathy is seen, which is the fluctuating type of lymphadenopathy. Okay, sometimes you get the lymphadenopathy, sometimes you get the resolution symptoms. Okay, so it is a waxing and waning type of lymphadenopathy. Okay, this is a very hallmark feature of the follicular lymphoma. So whenever you encounter a case of a patient who is having a lymphadenopathy, episodic type, Okay, intermittent or a fluctuating type of lymphadenopathy. That means you're discussing the case of follicular lymphoma. Okay, and when you zoom in into these follicles, what you can see are the cleaved cells. Okay, they have the cytoplasm which is very much cleaved, just like the coffee bean cells. Okay, you will see the when you zoom in those follicles, you will see the cleaved cells in case of follicular lymphoma. Is that okay? Okay.
Yes.
Okay. Now comes the mantle cell lymphoma. Okay, which is due to a translocation of 11 and 14 chromosome. On the 11, you will be having a cyclin D1. On the 14, you will be having a Ig heavy chain. Because of high level of cyclin D1, which are a proto-oncogene, you will be having a mantle cell lymphoma. They are very aggressive and generally present at a very late stage. Okay, so prognosis is kind of very much poor. Okay, and that would be all about it. And the cyclin D1, remember cyclins and the cyclin dependent kinases?
Yeah.
The cyclin dependent kinases, they will be continuously synthesizing in your body. And whenever they get the cyclin after a growth signal, they will get activated. And what they will do?
G1 to S transition.
How?
Retinoblastoma protein.
Yeah, exactly. They will phosphorylate the retinoblastoma and inactivate it, so that the retinoblastoma will release elongation factor 2 and the progression can happen. Okay, so that's how we get the mantle cell lymphoma. Then comes some marginal zone lymphoma. Okay, and it is associated either with the translocation of 11 and 18. Okay, on the 11 you will be having a cyclin D1, and on the 18 you will be having the BCL2. Okay, they are generally associated with the chronic inflammations. And please remember 2-3 names. First is the Sjogren syndrome. Second is the chronic gastritis, which you will see with the H. pylori. And third is the Hashimoto thyroiditis. Okay, remember the Hashimoto thyroiditis, in which you're having a lots of these the follicles in them.
Yes.
In the biopsy, right? And I told you that the Hashimoto thyroiditis can become the marginal zone lymphoma, right? So Hashimoto thyroiditis, Sjogren syndrome, and chronic gastritis, these three have a very high potential of becoming the marginal zone lymphoma. Very important. Okay. And then comes the primary central nervous system lymphoma. Okay, which is a primary CNS lymphoma, you can call it. It is caused by the Epstein-Barr virus, and it is a HIV-related disease. Due to deficiency of these lymphocytes because of HIV, the Epstein-Barr virus will get activated in the brain, and it will cause the primary CNS lymphoma in the brain. What you will see are the solitary lesions sometimes in the brain, or sometimes a multiple lesions can also be seen. But note that the multiple lesions are generally seen in the multiple ring enhancing lesions, I must say. Multiple ring enhancing lesions are seen in case of toxoplasma, but the multiple ring enhancing lesions can also be seen in case of Epstein-Barr virus. Okay. And but most commonly it would be the single lesion only, not the multiple type. Okay, so what you will get is the focal neurologic deficits because of this abscess thing. Okay, the ring lesions are because of abscess only, right? So you will get the brain abscess. Because of that, you will get the headache, you will get the fever, you will get this focal neurologic deficits. Along with the history of HIV, it will make you think about the Epstein-Barr virus. Is that okay?
Yeah.
And what you will see on the biopsy of the patient, because of Epstein-Barr virus, you will be having the atypical lymphocytes along with B lymphocytes. Of course, it is a tumor of B lymphocytes. Don't forget that it is not a T lymphocyte, which are tumorous cells. It is the B lymphocytes, and the T lymphocytes, which are atypical type, they're reacting against the B lymphocytes, right?
Yeah.
And you also have the CA20 marker positive for it. Any doubt?
In the atypical lymphocytes, they will be found on the biopsy or on peripheral blood smear.
On the PBS also and the biopsy also, because these lymphoma cells are also present there, right?
Oh.
In the brain.
Yeah.
So in both locations, you can find them.
Well, thank you.
Okay, so that's all about the neoplasms of the B cells. Okay, and these are all the non-Hodgkin's lymphoma. Then the non-Hodgkin's lymphoma, which are including the T cells. Okay. The first one is the adult T cell lymphoma, which is mostly seen in the Japanese patient. Okay. Please note, they will always give you a Japanese patient in these cases. It is caused by the human T cell the lymphoma virus, STLV, and it is associated with the IV drug abuse mainly. Okay. What you will see are the cutaneous lesions, because the T lymphocytes are also present in the skin. So what you will see is the multiple cutaneous lesions, some nodules, sometimes the ulcers. Okay, some kind of a rash would be seen. And above that, if the patient is from the Japan, you will think about the STLV. Okay. You can get the lytic bone lesions as well as the hypercalcemia because of the metastasis to there. Okay. So a patient with the skin lesions, with hypercalcemia, with lytic bone lesions, and a history from Japan, it will make you think about the STLV. Is that okay?
Yes.
And then comes the mycosis fungoides. Okay, it is a localized disease, and the Sézary syndrome is a diffuse disease. Very important. Okay, whenever the disease is localized, you will call it the mycosis fungoides. If the disease is kind of disseminated in your body, which means the skin and the organs as well as the blood involvement, you will call it the Sézary syndrome. Okay, in this case, you will be having a T cell neoplasm. First of all, it will only involve your skin. Okay, so you will having a skin patches or the skin nodules or the the skin plaques you will see. And when you do the biopsy of these lesions, what you will see are the cerebroform nuclei containing CD4 cells. You will be having a lymphocytes, and the lymphocytes will contain the nucleus in the form of like cerebrum. Okay, the nucleus have a shape like a cerebrum, and that's why you call them the cerebriform nuclei cells. The CD4 cells on the biopsy will be seen. Okay, and when the disease will become disseminated, it will go into your blood. You can even see these cells, the CD4 cells in the blood. Okay, and it can also go to the other organs like the liver or the spleen. So you can have the hepatosplenomegaly, and when you do the biopsy, you will again see the cerebriform nuclei cells. Okay, so it depends whether you are seeing these cells only in the skin, which means a mycosis fungoides. If you're seeing these cells in the skin, in the blood, in the other organs also, that means it is a Sézary syndrome. Is that okay?
Yeah.
So that's everything about the B cells and the T cells lymphoma. Any doubt?
No, thank you.
Okay, so we have discussed the tumor of the B lymphocytes and the T lymphocytes in the lymph nodes. Okay, now let's talk about the bone marrow disorders. Okay, which are the plasma cell dyscrasias, because you know that the lymphocytes ultimately be converting into the plasma cells, which will release the antibodies, right? So in these disorders, you will be having a high level of antibodies, right? You will be having a monoclonal immunoglobulin production. Okay, and it is because of the plasma cell disorder. So what you will have is a spike on the serum protein electrophoresis, SPEP. Okay, you will be having an antibody spike in it. Okay, and for the protein electrophoresis, you will use the proteins. You will place them on this agar medium, and you will make them move forward from the positive to negative. Okay, and then will look for the spikes. Generally, you will have a very high albumin level, which is normal because albumin is the most abundant protein in your body, in your blood. Okay, so you will be having a normal patient, you will be having a high level of albumin. Then you have the alpha chains and the beta chains again, and you have the gamma proteins also for the antibodies, right? So these kind of waves will be formed on a normal SPEP. In case of the plasma cell dyscrasias, because you're having a high production of this gamma chain of the antibodies, what's going to happen? You will see a M spike or this kind of a spike at the gamma chain level. And that's how you know that the gamma production is very much high in your blood. Okay, it could even more than the albumin. Okay, so as you can see, the total protein in your body is increased, and when you check for the the total protein minus the albumin, the difference will be very much high, right? And that's how you know the patient is having a plasma cell dyscrasia. Is that okay? Yes. Okay.
Yeah, okay. Yeah, okay.
Okay. Other thing that you can do is to detect the protein in the urine. And please note a whole antibody cannot pass through a normal intact kidney. Okay, it's only the Ig light chain which can easily cross this the barrier. Okay, what you call it, a hyperfiltration barrier, right? Only the light chains, which are very small proteins, they can cross these barrier, not a whole antibody. So in the urine, you can only detect the Ig light chains. Okay, you can again do the dipstick test. Okay, and because a dipstick test only detect the albumin, it will came out to be negative. So a proteinuria with a negative dipstick test, that means we're talking about the plasma cell dyscrasias again. Okay, and yeah, and when you have the whole antibodies, what case it could be?
Can you repeat what did you ask?
I told you that in case of a plasma cell dyscrasias, you will be having the Ig light chain only in the urine. If I'm getting a whole antibody, then what case it could be? When can I get a whole antibody in urine?
Nephrotic syndrome in the
Exactly,
intestine membrane.
nephrotic. Yeah, nephrotic syndrome, very important, right? So with a normal kidney, I can only get the Ig light chain. And can anyone tell me why this Ig light chain is in the urine, is present in the urine? While normally I won't get the Ig light chain, I won't get any protein, right?
Because of overproduction, overflow.
Exactly, because of the overproduction. And what will happen after the overproduction? High filtration load, right? Normally what happens, small amount of these Ig light chains and some other proteins, they will come into the kidney, into the tubules, but they will be reabsorbed, right? But when the threshold levels is reached, then all of these proteins will be coming into my urine, right? So it is due to the heavy load of these proteins, right?
Yeah, right. Thank you.
Okay, so confirmation is done by the biopsy of the bone marrow. You will see the plasma cells and you will know that the patient is having a plasma cell dyscrasias. Okay, the first one is a multiple myeloma in which you're having an overproduction of the IgG antibodies mostly. Sometimes IgA could also be involved. Okay, because of the metastasis of this, because the tumor is involving the bone marrow, they will release the cytokines and that will cause the destruction of the bone. So what you will have is the lytic bone lesions, and because of that, you will be having a bone pain like the back pain. Okay, and that back pain cannot be relieved by the NSAIDs or by any position change. Okay, when you do the X-ray, you will have the punched out lesions on the X-ray. Okay, and because of this bone resorption, you will be having a hypercalcemia also. Okay, the symptoms of the hypercalcemia includes the constipation. Okay, and the
Confusion.
diabetes insipidus, right? Confusions can also be there sometimes, right? So a patient with a constipation, a patient with the polyuria and the polydipsia, increase in the frequency of urine would be there. Renal involvement can also occur, and that can lead to the renal failure. Okay, what you will have is a waxy cast nephropathy. On the urine analysis, what you will find is the waxy cast, and whenever step one mentioned this waxy cast, you immediately know that the patient is having a multiple myeloma. The age of the patient is very important. Only the age more than 50 years, okay, the patient can have a multiple myeloma, not before that. Okay, and these antibodies will be reacting against your RBCs, and it will cause the anemia also, a normocytic normochronic type. Okay, on the PBS, you will have this inflammation, and because of the inflammation, you'll be having this Rolex formation, which is a stacking up of the RBCs upon each other, right? And do not confuse it with the clumping. Okay, clumping will be in the kind of group thing, and the stacking is in the linear pattern. Okay, this you will see
I have
on
a
the
question.
urine analysis. Yeah,
The anemia is because of metastasis to the bone marrow or because of
both
autoimmune?
things, both things,
Okay, thank you.
both things are there. Okay, where were we? Yeah, on the PBS, you will find the Rolex formation. On the urine analysis, what you will see are the Ig light chain spike first. You will detect the proteinuria. You will see the protein is there, but the dipstick would be negative. Okay, and you call them the Bean-Jones protein. Okay, which is nothing but the Ig light chains. A fancy name for that. Okay, on the bone marrow analysis, you will see more than 10% of the monoclonal. Very important, the word monoclonal plasma cells. Okay, these plasma cells will have a abundant nucleus with a very pale region in the cytoplasm, which we have discussed already because of the Golgi body, right? That's how you will diagnose the case of this multiple myeloma, right? And you will also have the intracytoplasmic inclusions of the IgG antibodies, because you know that these antibodies must be secreted by the body, by the cell. Okay, so sometimes you also get the aggregates of these IgG antibodies in the cytoplasm, right? So IgG aggregates along with these lattice regions and the large cells with large cytoplasm. And yeah, note the location of this nucleus. It is the at the periphery, right? Very important. At the periphery, you will find the nucleus, not in the center. This is also very much important. Okay. So yeah, uh, that's all. And because these antibodies are kind of defective, right? Because they're monoclonal, they're not polyclonal, so they cannot fight the infection much. So patient will also have an increase in risk of infection, along with the increased risk of amyloidosis, which is the Ig light chain amyloidosis. Is that okay?
Yes.
So whenever you get a patient with a history of constipation, back pain, which means mostly a lower back pain, okay, along with the high creatinine levels, okay, and the fatigue and old age, that means they're talking about the multiple myeloma always. Just think about the hypercalcemia, renal involvement, anemia, and the bone pain. These four symptoms, whenever you get that, you will always think about the multiple myeloma. They will also ask you about this protein type thing, which means, because you have a very abundant protein in the serum, and you will have a very elevated gamma cap, which means the difference between the total protein and the albumin is very much high. That means you have some elevated other protein also. In that case, the gamma proteins, right? Stephen can also ask you about this, and they can ask you why this uh, lytic bone lesions are found because of the release of cytokines directly by these cells, which will activate the osteoclast cells and inhibit the osteoblast cells. So it is a purely osteoclastic type of lytic lesion. Okay. Any doubt?
No, thank you.
Okay, then comes the Waldenstrom macroglobulinemia, in which you are having a IgM antibodies production instead of IgG antibodies. And because these IgM antibodies are very large and in a pentameric form, so you can see whenever you have these antibodies in the blood, they will first cause the symptoms of the viscosity, right?
Yeah.
So because of the symptoms of viscosity, you will get the headache, you will get the blurring of the vision. You will also get the clumping of the blood at the periphery sites like the fingers. So we'll get the Raynaud's phenomena also. You can also get the retinal hemorrhages. Okay. And most of the clinical features are due to the autoimmune effects of these IgM antibodies. Okay. Most of symptoms are because of the autoimmune effects, not because of the osteolysis. If you're having the hypercalcemia and the osteolysis, then you will always think about the multiple myeloma, not about this Waldenstrom macroglobulinemia. You won't get any lytic lesion, you won't get any hypercalcemia in this disorder, right? Okay, so because of the autoimmune, because of this autoimmunity against my peripheral nerves, I can get the peripheral neuropathy also, in which my extremities are mainly involved. I can get the paralysis of the extremities, I can get the fever, I can get the systemic signs and symptoms. Okay, and yeah, this neuropathy will be symmetric, okay, and the extremities will be involved first, and the paresthesia, weakness, all these things will be seen. On the labs, I will be having a high level of LDH, high level of uric acid. Of course, with any other tumor, I can get a high level of uric acid. I can get a high level of alkaline phosphatase also. Okay, and on the bone marrow analysis, what I will see is more than 10% of the plasma cells with past positive IgM antibodies. Very important. Okay, this is what I see in the bone marrow. Okay, the plasma cells, they will contain the IgM antibody inclusions, not the IgG antibody inclusions. Okay, so yeah, the complications will be the thrombosis. Okay, about the Waldenstrom macroglobulinemia, the main symptoms are because of the autoimmunity and because of the hyperviscosity. and no crab finding, which means a hypercalcemia, renal involvement, anemia, or the bony lytic lesions are found. Whenever these symptoms are found, you will always think about the multiple myeloma, not about this Waldenstrom macroglobulinemia. Is that okay?
Yeah, I have one question.
Yeah.
Is there any reason behind those lab values in Waldenstrom?
You can get them in any kind of tumor, I think. The high level of LDH will be there because, in any kind of tumor, you will be having a very large number of cells. They will
Yeah.
die and they will release the LDH. So it is kind of non-specific, not very much specific for that only.
Okay. Got it. Thank you.
It just, they will show you these labs. So, don't get confused. If they show you this lab, that means it could be a cancer.
Okay. Thank you. Yeah.
Okay, so these are the pure tumors now. And then you have a pre-tumor condition also, okay, which is a monoclonal gammopathy of undetermined significance, in which you are having a monoclonal plasma cell production, but it is less than 10%. In order to get a cancer, either the multiple myeloma or the Waldenstrom macroglobulinemia, you need at least 10% of the plasma cells in the bone marrow. In this condition, you will be having a less than 10%, but still a very high level of the monoclonal plasma cells. So it is kind of a pre-cancerous condition. Okay, usually this condition is always asymptomatic. When you do the biopsy, you will see the high number of these plasma cells. Okay, and the risk of the multiple myeloma will be increased 1 to 2% per year, because with the successive years, you will be having an increased production of these monoclonal cells. And once these cells reach a 10% limit, they will become the multiple myeloma. Okay, and they can have any production of the antibody, either the IgM or the IgA or the IgG, right? So they can become any type of cancer. Is that okay?
Yes.
And that's why the name undetermined significance, because we do not know what kind of tumor it's gonna form in the later disease. What is significance of this monoclonal plasma cell proliferation, right? We do not know, and that's why we call it the undetermined significance. So, any doubt on this page?
No, thank you.
So remember these cells, the eccentrically placed nucleus first at the periphery, that means, and on the cytoplasm, you will be having this pale cytoplasm region, which means a Golgi body will be there. And sometimes you can even see the inclusions in the cells, right? Either the IgG inclusions or the IgM inclusions. Then comes the myelodysplastic syndromes. In case of myelodysplastic syndromes, you will be having, the replacement of your normal bone marrow, okay, with some dysplastic type of cells. Okay, and these dysplastic cells can be formed after some kind of a radiation exposure or some kind of a chemotherapy, right? So it would always be a patient who is having a history of any other cancer, and he's receiving some chemotherapy or some radiation for that, and now he's having the dysplastic RBCs or other lineage cells in the bone marrow. Okay, very important to note first. So what's going to happen in that, your bone marrow will be filled with the abnormal type of myeloid progenitors. Very important, the myeloid progenitors will be there. Okay, and because the abnormal type of cells will be replacing the normal parenchyma of your bone marrow, you will be having a pancytopenia. So the first complaint will be the pancytopenia. Okay, and now because the cells will be produced, but now the dysplastic cells will be produced. What you will see are the dysplastic RBCs, which are the oval macrocytes on the PBS, right? You will have the dysplastic neutrophils, and these are not the hypersegmented, but the hyposegmented neutrophils. So remember, for the hypersegmented neutrophils, it is the vitamin B9 or the vitamin B12 deficiency. In case of hyposegmented, which is a dysplastic neutrophils, it is because of myelodysplastic syndromes. So it's nothing but a replacement of the normal bone marrow with the abnormal type of dysplastic cells. You will get the pancytopenia, and these dysplastic cells will proliferate and they will form the dysplastic RBCs. They will form the dysplastic neutrophils, right? Which you can easily detect in the this PBS. Okay, hepatosplenomegaly won't be seen. Okay, very important to note again. And what you will see on the bone marrow is not the hypocellularity, but the hypercellularity because of these dysplastic progenitor cells. Step 1 can ask you this fact. Okay, why in the bone marrow you are having the hypercellularity even though you are having the pancytopenia? It is because of the dysplastic progenitor cells. Okay, and you can also have the pseudo Palgar-Huat anomaly, okay, which is nothing but just a bilobe nucleus of the neutrophils. Okay, and the patient will also have a risk of increase in the AML. Okay, the risk of AML is there. So, any doubt on the myelodysplastic syndrome?
No, thank you.
Okay, so we have discussed every lymphoma. We have discussed the bone marrow disorders. Okay, the multiple myeloma, the Walden's myeloglobinuria. Okay, the undetermined significance disease, gammopathy, and the myelodysplastic syndrome. Now the time of blood. Okay, and it is leukemias we need to discuss. So in case of leukemia, you will be having a very high production of the WBCs. Okay, and this WBC production will be very unregulated. Okay, and the differentiation will be very much kind of abnormal, right? And ultimately that will lead to the bone marrow failure, because all of these cells will be start replacing the bone marrow, right? And what they will cause is the pancytopenia. Okay, first thing you will have the anemia, and because of that you will be having a fatigue, which is a first common presenting complaint of the patient. They will run out of breath very early. Okay, they have this fatigue thing, they have this paleness in the body. Because of the immature WBCs, you will have the increased risk of infection. Because of the low level of platelets, you can have an increased risk of bleeding also. Okay, some conditions can also be associated with the Down syndrome. Okay, and once you do the peripheral blood smear, what you will find is the lymphoblast cells sometimes. Okay, and sometimes you can even see the lymphocyte cells also. Okay, and you can also do the bone marrow examinations to see for the these tumor cells, right? And yeah, and so you will have a high count of WBCs, but all of the WBCs are kind of defective type, and that's why you are having an increased risk of infection. Now, because the tumor is already in the blood, so I can say that the tumor has already metastasized, right?
Yeah.
So these leukemias can never be a benign condition. It is always a malignant condition. Okay, they can go to the liver, they can go to the spleen, they can go to the lymph node, they can go to the skin, they can go to the bone marrow. If they go to the bone marrow, they can cause the pancytopenia. If they go to the lymph nodes, they can cause a multiple lymphadenopathy. They can go to the spleen liver, they can cause the hepatosplenomegaly also. In the skin, they can cause the skin nodules, skin rashes. Okay, this is known as leukemia. This is known as a leukemia cutis. Okay, so these are all the common presenting complaint of every leukemia. It is common for every leukemia. Okay, so let's discuss some specific features of every leukemia, right? So first is the acute lymphoblastic. Please note the name. It is lymphoblastic, not a lymphocytic, because it is an acute condition. Okay, it is most frequently seen in the children. Very important. In the adults, it can also be seen, but the adults generally have a very worse prognosis. Okay, and most of them are kind of the B cell tumors. Okay, the B lymphocytes, but sometimes it could also be the T cell acute lymphoblastic leukemia, and whenever it is a T cell, it generally present with a mediastinal mass. And you guys know that if any mediastinal mass is present, then it can compress the superior vena cava and it can cause the superior vena cava syndrome, right? It can also compress the esophagus to cause the dysphagia. It can also compress my recurrent laryngeal nerve to cause the hoarseness. So whenever you encounter children having a dysphagia, hoarseness, and this edema of the face, along with the pancytopenia, fatigue, and other things, that means we are looking for a case of acute lymphoblastic leukemia. Okay, and you will have a very high count of lymphoblast, which are the immature lymphocytes. This condition is also associated with the Down syndrome. As we have discussed, some of the conditions are associated with the Down syndrome also, and this was the one. Okay, and why Down syndrome? Because in this case, you will be having a translocation of 12 and 21. And on the chromosome number 21, you will be having a Down syndrome, right? But the patients with the Down syndrome, if they have this condition, then they have this better prognosis. Okay, and because of the presence of blood-brain barrier, okay, and these tumors can go anywhere, right? So you need to give the patient special chemotherapy for the CNS and the testis. Okay, very important. And the important thing that you need to remember are the CD markers. Okay, and because of the presence of because these are kind of immature cells, right? So they still have the function of this something known as a TDT. And remember the function of this TDT enzyme?
For VDJ recombination.
It is not for the VDJ. VDJ recombination is happening, but once the VDJ recombination has occurred, it will randomly add the nucleotide at the end of the sequence, so that more specificity can be added, right? And it is only happen in the immature cells, not in the mature cells. Is that okay?
Yes.
So that's why this TDT will be activated only in the immature B and the T cells. So this is a marker for the acute lymphoblastic leukemia. Second thing would be the marker for the B cells, which are the CD10 markers. For the T cell, you will be having a 1, 2, and 5. So CD1 to 5 is for the immature T cell. CD10 is for the immature B cell. And apart from that, you will also have the TDT positive. So whenever you get these kind of markers, you're looking for the acute lymphoblastic leukemia. Is that okay?
Yeah.
And please note, in the step 1, it is always going to be a case of child, not adult. Then comes the CLL, or the chronic lymphocytic leukemia. Please note, it is cytic, not a blastic. So you won't see the blast cells, but you see the mature lymphocytes in it. It is seen in the adults more than age of 60. Okay. And because the mature cells are there, so you will be having a normal CD markers of the B lymphocytes, like the CD20. You will also have a CD23, CD5. Okay. Other than that, CD19, CD21 is also positive in that cases, right? What you will see is the smudge cells, which are the crust lymphocytes. Okay. This is how you see these cells. These are the smudge cells. Okay. So this is what you see in case of chronic lymphocytic leukemia, the smudge cells. They will give you this peripheral blood smear. You need to identify these cells. Very important. Okay, so this is an important find, the crust lymphocytes. Okay, you will also have the autoimmune hemolytic anemia in that case. Okay, so if you have the anemia, you will have the pancytopenia completely, right? Sometimes this, this CLL or the SLL can also be transformed into the aggressive lymphoma, which is mostly the diffuse B cell lymphoma or the large B cell lymphoma, right? And yeah, that is known as a Richter transformation. Nothing much special about it. So a patient having a history of pancytopenia along with these smudge cells on the peripheral blood smear, okay, with the CD20 marker positive, that means we're looking for the chronic lymphocytic leukemia. Is that okay?
Yes.
Then comes the hairy cell leukemia. Okay, and the one thing you need to remember is the trap. Okay, these cells are trapped. Okay, and these cells are also trap positive. Okay, so these are found in the adult males. It is a B cell tumor. Okay, the cells will have a hairy projections, and that's why the name hairy cell leukemia, of course. And if I show you, these cells will look like this. They have this kind of hairy projections on them, and that's why the name hairy cell leukemia. So whenever you encounter a case of a patient in step 1 with the PBS showing these kind of a hairy projections from the cell, that means we're looking for the hairy cell leukemia. You need to identify the hair very carefully. Okay, so yeah, so they have this hair-like projections, okay, which gives them a very fuzzy appearance, hair-like appearance. Okay, the lymphadenopathy is very uncommon, very important. These cells are kind of trapped in the spleen. You can think it about like that. These cells are trapped in the spleen and in the bone marrow. So on the bone marrow, you will get a dry tap because of the replacement of the normal bone marrow. Okay, you will get the fibrosis. You will get a dry tap on the aspiration. Because these cells are trapped in the spleen, you will get the splenomegaly. These cells cannot go anywhere, so you won't get any kind of lymphadenopathy. So a case of pancytopenia with a dry tap, just like the aplastic anemia, okay, but without lymphadenopathy and with the splenomegaly, okay, you will think about the hairy cell leukemia. Okay, and yeah, these cells are the target resistant acid phosphatase positive, which is a trap. Okay, and these cells are associated with the BRAF mutation. Remember other mutations, the other cancers that can happen because of the BRAF mutation?
Melanoma.
Okay, melanoma, 1, hairy cell leukemia, 2nd, and Any thyroid cancer?
Papillary thyroid.
And any pancreatic, I think it was also there, right? BRAF for the pancreas. Was it?
Not sure about that.
So you have the papillary thyroid carcinoma for that. You will have the melanoma. You will have this Heme cell leukemia. I'm also not sure about the pancreatic adenocarcinoma if it is associated with that. Let me check. Just give me a second.
No.
Just a second. No, you don't have it. Okay, you don't have it, right? You have the KRAS mutations for the pancreatic adenocarcinoma, okay? Not the BRAF. I got confused it with the KRAS, okay? So BRAF for the Heme cell leukemia, for the melanoma, and for the papillary thyroid carcinoma. Please remember that, okay? And you give the patient cladribine. Remember the cladribine, which is the adenosine deaminase enzyme inhibitor? And we have discussed how this adenosine deaminase, if I inhibit this enzyme, then the level of the adenosine will rise, right? And this adenosine is a lymphotoxic substance, right? So it will cause the apoptosis of these cells, and that's why the cladribine is kind of very much effective therapy in case of hairy cell leukemia. Is that okay?
Yes.
So remember about the cladribine, remember about the BRAF mutation, remember about the trap only. These cells are trapped in the spleen, cannot go anywhere. You will get a dry tap in the bone marrow. You won't get any lymphadenopathy, but you will get the massive splenomegaly. You will get the pancytopenia, and you will get the hairy cells, of course, as the name suggests, hairy cell leukemia. Right?
Yes.
Yes.
Okay, so that's about the lymphoid neoplasms. Let's talk about the myeloid neoplasms. And just like the acute lymphoblastic leukemia, I also have the acute myelogenous leukemia, okay, which is again seen in the old age patients, okay, and all these immature cells, they have the OR rods positive, okay, and these OR rods are kind of a procoagulant substance, okay. Whenever I have the OR rod in my blood, okay, my cognitive system will get activated and it will cause the DIC because of these OR rods, okay. They also has the myeloperoxidase positive. Remember the function of this myeloperoxidase?
Converts
Oxidative
it.
burst.
Respiratory burst.
Speak one by one.
Oxidative burst.
Respiratory
Yeah,
burst.
exactly. Oxidative burst. Okay. So because these myeloid cells are involved in the oxidative burst, the neutrophils mainly, so you will have a positive myeloperoxidase activity, and the crystals of this myeloperoxidase are known as the OR rods. And let me show you the OR rods. Mostly they will give you the PBS in case of acute myelogenous leukemia, and every PBS will show these OR rods, these kind of a rod-like structures in the cytoplasm you will see. And whenever, as you can see in this neutrophil also, this is a rod-like structure. If you guys can appreciate that, right? This is a rod-like structure, as you can see. Okay. So whenever you see the rod-like structures in the cytoplasm, you will immediately know that it is a case of OR rod, which means the acute myelogenous leukemia, right?
Yeah.
Okay. And you also know that for the specialization of the cells, you require the vitamin A, right?
Yes.
In case of acute myelogenous leukemia, okay, what's gonna happen? You will have a translocation at the 15 and 17. Okay, and just give me a second. Yeah, in this case, you will be having a translocation of the PML and the RAR alpha. RAR is for the retinoic acid receptor, and PML is for the promyelocytic leukemia, right? So you will be having a translocation of the promyelocytic leukemia gene, which is on the 15, and the retinoic acid receptor alpha gene for the on the chromosome number 17, right? So because of this translocation, you will be having the acute promyelocytic leukemia, which is the most common variant of the acute myelogenous leukemia, right? And if you give the patient vitamin A or the all transferrin receptor, then the maturation of these cells can occur, okay, and we can get rid of the this neoplasm. Is that okay?
Yeah.
And the most common presenting complaint apart from the pancytopenia is the DIC. Okay, you will get the pancytopenia for sure, but you will also get the DIC. The clotting symptoms will be there in the patient. The bleeding from the IV sites, the bleeding from the eyes, bleeding from the mouth, or the hematoses could also be there, right? So that's how the patient with the AML present to it. Okay. Of course, they will have the anemia also. So they will have the fatigue, they will have this paleness, they will also have the bleeding complications because of thrombocytopenia. They will also have the recurrent the infections because of the neutropenia, right? And they will have the high PT, high PTD, as well as the high bleeding time. Okay. Any doubt in it?
No, thank you.
Okay. Okay, now comes the other leukemias. We are discussing about the myeloid neoplasms and now the chronic myelogenous leukemia, in which you are having a more mature cells in the blood, right? In case of acute myelogenous leukemia, I was having a immature cells in my blood. In case of CML, I will be having a mature cells in the blood. As you can see, the neutrophils are there, the eosinophils are there, right? And the lymphocytes, the monocytes are also there, right? So more mature cells I will be seeing in my peripheral blood smear in case of CML. It has happened because of a 9,22 translocation, okay, which can lead to the BCR ABL gene fusion, okay, and this chromosome is known as the Philadelphia chromosome because the disease was identified first in the Philadelphia. That's why the name, okay, and so you will have a dysregulated production of the mature and the maturing granulocytes because we have discussed that tumor is of myeloid cells, which means the granulocytes, right? So what you will get is the neutrophils, the myelocytes, as well as the basophils. Okay, you will also get the hepatosplenomegaly for sure. Lymphadenopathy will be there. Okay, and this tumor can accelerate and can also form the AML or the ALL. Okay, which can lead to the blast crisis. Just a fancy term for that. Okay, you will have a very low activity. This is a hallmark feature of this tumor. See, in case of a leukemoid reaction, in which you're having a reactive hyperplasia of the lymphocytes, you will be having a very high level of this of the lymphocytes, right? More than 50,000 or more than 90,000 even. In that case, you need to always look for the leukocyte alkaline phosphate activity. If the leukocyte alkaline phosphate activity is very much high, okay, that means you're having a working neutrophils, okay, which is kind of because of infection only. But if the LAP level is very much low, that means these are the dysfunctional leukocytes, which means it is a cancer. Apart from that, you can also look for other hints like the dole bodies we have discussed, like the like the vacuolated cytoplasm of the neutrophils, right? And this, yeah, and these are the things. So in both the cases, you will be having a more immature form in the blood. You will be having a more this, what you say, more number of lymphocytes in the blood. But the only thing that it will look forward is for the leukocyte alkaline phosphate and for the other morphological features of the neutrophils, right? So that's about the chronic myelogenous leukemia. And of course, you will have the pancytopenia again in case of chronic myelogenous leukemia, right? Yeah. So because that after the fusion of the BCR ABL, it will synthesize some growth factors, okay, that will again stimulate a tyrosine kinase receptor. Okay, so you need to inhibit this receptor, right? It is kind of a mutation in the tyrosine kinase receptor, so you need to give the patient imatinib, which is a receptor tyrosine kinase inhibitor. That's why the name nib in it. If you guys remember from the nomenclature of these antibodies, we have discussed that every tyrosine kinase inhibitor will have name nib in it, right?
Yeah.
So it is the imatinib which you will give, which will inhibit the tyrosine kinase, and as a result, these growth factors or the receptor itself cannot stimulate the production. Any doubt in CML?
No, thank you.
Okay, so we have discussed the leukemias completely. Okay, so these were the WBCs, and so we have discussed the lymphomas, right? We have discussed the bone marrow tumors. We have discussed the leukemias, all about the WBCs, right? And now we need to discuss the tumors of the RBCs and the platelets. And these are known as the chronic myeloproliferative disorders. And these disorders can also have some impacts on the WBCs also, right? And all of these disorders are because of the JAK2 mutation. You guys remember from the endocrine lectures we have discussed that every blood cell, every cytokine, okay, every growth of the blood cell, they will require the JAK-STAT pathway, right?
Yeah.
So if you have a mutation in the JAK-STAT kinase pathway, in that case, you will be having a very high proliferation of these RBCs or the platelets, right? So let's discuss first about the polycythemia vera, in which because of the JAK2 mutation, you will be having a very high production of the RBCs, right? A very special thing that you will get is the aquagenic pruritus, which means whenever you expose yourself to a hot water, okay, you will get the itching in the body. Very important, okay? You will get the erythromelalgia, okay? Because of the high viscosity of the, so because of the high RBC count, you will have a very high viscosity, right? And you will get the viscosity symptoms, right? Just like the headache, the blurring of the vision, right? You will also get the burning pain, okay? And you will get a reddish bluish discoloration of the hand, as you can see here in this diagram also. Okay, you will get a swelling of the hand because of the vaso-occlusion. You will get a very reddish hand there, right? And yeah, so it is because of the episodic blood clots in the vessels of the extremities. So we'll get a burning pain, you will get a red discoloration. And now because the blood flow is also decreased because of this high viscosity, okay, the blood flow is also decreased. So you will also get the peptic ulcer disease in case of polycythemia vera. Okay, and because the RBC turnover is now increased, so you'll be having a very high uric acid level. So that can also leads to the gouty arthritis. Okay, and because it is kind of a tumor, okay, which is affecting the RBCs directly, it is because of internal mutations in the formation of RBC. So the EPO level will be absolutely decreased, right? Because the EPO will stimulate the synthesis of the RBCs. Okay, now because you're already having a so much high level of the RBC, so these APU levels will be decreased, right? And yeah, that's it. And so treatment will include a rituximab. Sorry about that. It will include a phlebotomy in which will remove the RBCs. It will include a hydroxyurea. Okay, it will also include some ruxolitinib. Okay, ruxolitinib, which is again a tyrosine kinase inhibitor. See the name NIB in it, which is for the tyrosine kinase inhibitor. And in that case, it is a JAK1 and JAK2 inhibitor. Very important. So, and yeah, could we have the splenomegaly or the hepatomegaly in case of polycythemia vera?
Yes, because sequestration of RBCs by spleen,
Because of sequestrations of the RBCs.
like there is increased formation of blood cells, so spleen will.
Okay, that could be one cause. Any other cause? Because of all these tumor cells which are forming the RBCs, they can go anywhere right now, right? So these progenitor cells, which are the tumor cells, they will lodge in the spleen, they will lodge in the liver, and there they will form the RBCs, right? That's how you know. That's how you get the expansion of the red pulp, and that's how you get the splenomegaly. Is that okay?
You mean to say extramedullary hematopoiesis?
Yeah, something like that. But it is a tumor. It is not a natural type of thing, right? Something
Yeah,
like that. But
mechanism is same, right?
yeah, mechanism is same. Yes.
Okay, thank you.
So once you do the biopsy of the liver, okay, what you will see is the extramedullary hematopoiesis. You will have the progenitor cells in the liver and the spleen. That's why the that's why this hepatosplenomegaly. Okay.
Yeah, okay.
Okay, now comes the essential thrombocythemia, in which you're having a very high production of the megakaryocytes, and so does the platelets. Okay, you will be having a very high number of platelets. But see, all of these disorders are involving a JAK2 mutation. So in case of polycythemia vera, it's not just you're having only the increased RBC. Along with that, you will be having a high production of WBCs, also high production of platelets also. Similarly, in case of essential thrombocytopenia, you will be having sometimes a high production of, RBCs also as well as WBCs, but not every time, sometimes only, right? Okay, so erythromelalgia can also occur in that conditions. You will have a mildly increased number of platelets, okay? And these platelets are kind of very much large, okay? and abnormal, of course. So nothing important. And because these platelets are kind of dysfunctional type, you will have the bleeding along with thrombosis. Okay, very important. And again, you can also have the hepatosplenomegaly in case of essential thrombocythemia. Okay, then comes a myelofibrosis, which is a tumor of the megakaryoplasts. Okay, and you will be having a high level of these megakaryocytes, and they will release the platelet-derived growth factors, and they will cause the fibrosis of the bone marrow. So because of the fibrosis, you will be having a pancytopenia type thing. You will be having a dry tap on the bone marrow. Okay, because of the fibrosis, all of the progenitor cells of the bone marrow, they will be sequestered out of the bone marrow, right? They will be thrown out of the bone marrow, and while doing that, they will become the teardrop cells. So what you will see on the PBS is the teardrop cells, as you can see here, right? And you have this fibrosis, which is the collagen deposition you will see in the biopsy of the bone marrow. Is that okay? You will have the dry tap, you will have the hypocellularity of the bone marrow. And you will also have the hepatosplenomegaly. Why? Because all of these progenitor cells, they will move, okay, from the bone marrow to the spleen and the liver, right? And so you will also get the hepatosplenomegaly. Okay, please note these are not the tumor cells, these are the normal cells which are found in the spleen and the bone marrow, right? Sorry, spleen and the liver. Okay.
Yes.
Could you explain why we are getting fibrosis in myelofibrosis?
Because the megakaryocytes, they can also release the platelet-derived growth factors, okay, and the fibroblast growth factors. So by releasing them, they will activate the fibroblasts, and the fibroblasts will cause the fibrosis. Just like you will get the osteoarthropathy in case of any kind of damage when happened to the vascular structure of your lungs. You have discussed that case of the cyanosis and the clubbing. Remember
Yeah, I remember.
the osteoarthropathy?
Yeah, actually, I'm confused. Is it because of platelet dry growth factor, or is it because of TGF beta?
In this case, it is because of the fibroblast growth factor and the PDGF.
Both, right?
Both, yes. Mainly the PDGF and then the FGF. Okay. I didn't hear about the TGF beta, so I'm not sure if the TGF beta is involved or not. But surely you have the involvement of PDGF and the FGF.
Okay, thank you.
Yes. Okay, so if you look for this table, okay, so you will have the Philadelphia chromosome positive only in the CML, okay, in which you're having a high level of WBCs and some platelets also, but a low level of RBCs, and the JAK2 mutations are absent, of course. In case of myelofibrosis, you will be having a low level of RBCs because of the dry tap, because of this, the fibrosis of the bone marrow. You will be having a varying level of WBCs and varying level of platelets again. JAK2 mutations are also positive. For the essential thrombocythemia, you will having a very high level of platelets. Sometimes you can also get the high level of RBCs because they also involve the JAK2 mutations. And for the polycythemia vera, you will be having a high level of all these cells along with the JAK2 mutation. So yeah, that's everything on this page. Any doubt on this page?
No, thank you.
Okay, now comes the causes of polycythemia. Okay, you can have two types of polycythemia. One is the absolute type and one is the relative type. What does that mean? Whenever you have an absolute increase in the mass of RBC, because the RBC proliferation, then I can say the patient is having an absolute polycythemia, right? But whenever I have a the plasma loss or the dehydration, let's say, whenever I have a free volume of water loss, in that case, relatively my RBC number will be increased because what I measure is a hematocrit, the percentage, right?
Yes.
And even in case of hemoglobin, because I measure the hemoglobin per deciliter, if I decrease the volume of blood, then I get the increased level of hemoglobin also.
Yeah.
So in all these cases, I can have two types of polycythemia. One is the absolute type and one is the relative type. So how can I identify whether the patient is having a absolute type or a relative type?
EPO levels and oxygen saturation.
Okay, oxygen saturation is one thing, good. EPO level could be used. And the most important thing is the RBC mass I have to look for. Okay, there is some kind of a element I use to get the RBC mass. Okay, radioactive substance was there. I'm not exactly remember the name. Okay, but it just substance was there in which I will do the this. Just give me a second. Yeah, there was a stance which could be used for the RBC mass determination. So first thing I will check is the RBC mass. If I have the increase in RBC mass, that means I'm having the absolute type. If I have a normal RBC mass, that means I'm having a relative type. Okay. So first I discuss the relative type in which you have a loss of plasma volume, but RBC mass will be absolutely normal. Okay. The oxygen saturation will be normal. Okay. The EPO levels are again normal. Okay, and this thing could be happen with the dehydration or could be with the burns or could be used with the diuretics. If you use the diuretics in the acute state of the edema, then you will have a free volume loss of the water, and as a result you will get the this relative polycythemia. Is that okay?
Yeah.
Second is the appropriate absolute increase. So appropriate means it should be happening, right? And the major cause includes the decrease in oxygen saturation. Now, because you have the hypoxia, your body will always try to compensate the hypoxia by increasing the RBC's level so that more oxygen could be carried, right? So in that, you will be having an increased level of RBC mass and the EPO levels will also be increased. Like in case of any high altitude or in case of any lung disease or any congenital heart diseases or a heart failure, right? Or regular exercises can also do that sometimes. And yeah, that would be all case or any cause in which you're having an increased affinity of the hemoglobin for the RBC. In all of these causes, you will be having a high RBC mass. Okay.
Yeah.
Then comes the inappropriate absolute value. Okay, in which you're having a high level of EPO, which means a tumor of EPO releasing. Okay, which means a juxtaglomerular apparatus. You guys remember?
Yes.
If I get a tumor of the JG apparatus, in that case, this tumor will be releasing more EPO, and as a result, I will get the high RBC mass. Okay, my oxygen saturation will be normal, plasma volume will be normal, but the EPO levels, because they are rising, they will stimulate the RBC to form the more of this, right? In case of polycythemia vera, we have discussed because of an internal mutation in the RBC formation, you will get the high RBC mass. Okay, apart from that, you can also sometimes get the high plasma volume also. Your body will try to compensate that because, and you will get a very low EPO levels. Okay, because this high level of RBCs will give the negative feedback to the EPO production, right?
Yeah.
So these are all the causes of the polycythemia. Don't forget that. Okay. Any doubt?
I have one question.
Yes.
Why is there a rise in plasma volume in polycythemia vera?
Because because of the super high increase in the RBC mass, the viscosity of the blood will be increased.
Okay. So to
And
manage
when to manage that, your body will try to increase the plasma concentration also.
Okay. Yeah. Thank you.
We have discussed all of these chromosomal translocations. Okay, no need to discuss them again. Just remember everything about them. The 814 Burkitt, 1114 for the this mantle cell. Okay, 1118 is for the marginal zone. Okay, 1418 for the follicular, and the 1517 for the APL, and 922 for the CML. Okay. Then comes the Langerhans cells histiocytes. So the histiocytosis. Okay, and see, these Langerhans cells, they are kind of a mix between the dendritic cells as well as the macrophages. The macrophages which are found in the skin, you call them the Langerhans cells. Okay, and as well as sometimes the dendritic cells are also known as the Langerhans cells. So they are not a purely dendritic cells. They are not purely macrophagic cells. They are in between the dendritic cells and the macrophages. Is that okay? Because some research papers, they mention the Langerhans cells and the dendritic cells. And some research papers, they have mentioned the Langerhans cells as the these macrophagic cells. So no one is sure what type of cells these are. Okay.
Yeah.
Okay, so the most important thing which you need to remember that it is a skin disorder, okay, because these cells are found in the skin. So you will get the skin rash first, okay, and you will also get the mass involvement with the mastoid bone. So we'll get a mass on the mastoid bone. You can forget that, doesn't matter, okay. But the most important thing about them is the Barbeck granules, which is a tannish, the racket shape of these granules which are found on these cells. Okay, on the electron microscopy, you will find these tannish racket shaped granules. Okay, this is the most important thing, and the second most important is the S100. These cells are positive for the S100. So whenever you get a S100 marker positive cancer, you will always think about the melanoma, schwannoma, and the Langerhans histiocytosis. Is that okay?
Yes.
Okay, and just give me a second again. See, similar name of cells are also found in the granuloma, right? The Langerhans cells. Okay, so please remember the Langerhans cells are different cells, and the Langerhans cells are different cells. Langerhans cells you will found in the granulomas, okay, which are the giant cells you call them. Okay, the Langerhans cells. Remember?
Yes.
So these are Langerhans cells. In here, in the histiocytosis, these are the Langerhans cells. Okay, do not get confused. They will give you both the names, so you need to identify. Okay, so study that more carefully. Langerhans or Langhans. Langhans are found in the giant cells, and Langerhans are here, right? So just two things about these cells. One is the Barbeck granules, and second is the S100 positive, and they're found in the skin. Any doubt on this page?
No, thank you.
Then comes the tumor lysis syndrome, okay, which is again, whenever you have a tumor and you give the patient chemotherapy, the chemotherapy will destroy the cells, the tumor cells. And whenever the cell destroyed, every component of the cell will be released, like the potassium, calcium, phosphate, uric acid. The potassium will be released and you will get the hyperkalemia, okay, and the phosphate will be released. This phosphate will cause the hyperphosphatemia. And because you guys already know that high phosphate level can bind to the free calcium, right? So they will bind to the calcium and they will cause the hypocalcemia. And uric acid from these cells will also be released and it will cause the hyperuricemia. Okay, so because of the because of the hyperkalemia, you will get the muscle weakness and the arrhythmias. Remember the QT prolongation?
Yes.
Because of hypocalcemia, you will also get the spasms. You will get the QT prolongation again. You will get the seizures. You will get the tetany. Okay, you will also get this two signs. Remember the Trousseau sign and the Shivastek sign?
Yeah.
You will get that, right? With the high level of phosphate, it will form the calcium phosphate crystals that can cause the kidney stones. Okay, with the high uric acid levels, they can also cause the uric acid stones. Okay, and apart from that, you will also have a high level of LDH, because LDH is the marker of cellular destruction. So a high level of LDH, high level of uric acid, high level of phosphate, high level of potassium, and a low level of calcium. This is known as the tumor lysis syndrome. The most feared complication is basically the uric acid crystals, right? And so that you need to prevent this condition by giving the patient allopurinol. Remember the function of the allopurinol?
Xanthine oxidase inhibitor.
So that it will inhibit the formation of uric acid. Or you can also give the patient rusfericase. Remember the function of rusfericase?
Converts uric acid to allantoin.
Yeah, which is a more soluble form, so that it could be easily excreted from my kidney without making the crystals, right?
Yeah.
So that's all about the tumor lysis syndrome. Then comes the any doubt in that?
No, thank you.
Okay, then comes the hemophagocytic lymphohistiocytosis. As the name suggests, hemophagocytic, that means I'm phagocytosing my RBCs and my heme, right? And it is a lymphohistiocytosis, which means the proliferation of the lymphoid cells as well as the histiocytes. Okay, it is generally seen in the patients with the Epstein-Barr virus infection mononucleosis. Whenever you encounter a case of the infectious mononucleosis, you can have this condition, okay, in which you are having a hyperactivation of the macrophages and the CD8 cells. Please remember, you will be having a hyperactivation of the macrophages and the CD8 cells. Now, because of that, these cells will engulf other cells in the bone marrow. So this is a condition in the bone marrow only, right? So in the bone marrow, these macrophages and the CD8 cells, they will be engulfing and killing every other cell, right? So they will get a pancytopenia. Okay, all of the iron will be released, and you will get the high ferritin levels on the labs because of the high macrophages. Because all of the ferritin ultimately, where does this stored? The ferritin will be stored where?
Macrophages.
Exactly. And you're having a high activation of the macrophages. It will engulf all of the RBCs, all of the heme. So you will having a very high level of ferritin also. Just like any other tumor, you will get the fever, you will get the weight loss. Okay. Spleen and liver involvement will also be there, right? And what you will get on the on the physical examination, we get the hepatosplenomegaly. Once you do the biopsy of the liver and the spleen, what you will see? Macrophages phagocytosing the RBCs, like we have discussed. Okay, the macrophages phagocytosing the bone marrow elements, especially the RBCs, you will see. That's why the name hemophagocytic, right? So these are a systemic overactivation of the macrophages and the cytotoxic T cells. You will get the fever, pancytopenia, hepatosplenomegaly, and a very increased serum levels, serum ferritin levels. Okay, it is seen after the Epstein-Barr virus infection. On the biopsy, what you will find are the macrophages phagocytosing the bone marrow elements or the RBCs. Is that okay?
Is it a malignancy or is it a post-infectious state or condition? Just
It is kind of a post-infectious condition also only. Okay, but it could be a result of malignancy. It's just a hyperactivation
So
syndrome. You can think about that. It is just a hyperactivation syndrome. Your immune cells are being hyperactive.
okay, I got it. Thank you.
Yeah. It could be seen after the infections. It could be generally seen after the malignancy also, in which you're having a high production of these immune cells, right? Then you can have this condition. So you cannot say if it is a proper tumor condition, right? It is a result of other conditions ultimately, right?
I see. Thank you.
Yes. So any doubt?
No, thank you.
Okay, so we are done with the hematology, embryology completed, then anatomy, then physiology, and then the pathology. And tomorrow, I think we'll discuss the pharmacology, and we will start with the MSK chapter. Okay, the musculoskeletal.
Okay.
Okay. Thank you so much, everyone.
Thank you so much.
Thank you.
Thank you.
Thank you.
Thank you.